Trichy, and she's also the secretary of the Trichy Hobby Society for the last 2 years. Welcome, madam, also to this organization. And may I call upon Dr. Asha Rao, madam, to please invite the next speaker, ma'am.
So let the chairpersons invite the next.
Madam, you're muted, ma'am. Ma'am, you're muted. Asha,
No,
madam, you're muted.
chairpersons, let them invite the next speaker.
Yes, ma'am. Yes, ma'am.
Yeah.
Sure. Over to you, the chairpersons, please.
Good evening, and it's indeed a great honor for me to be a part of ICOG certificate program. Sincere thanks and gratitude to Ramani Devi madam, Pratik Tambe sir, Sheila Menon madam, and all Asha Rao madam, and all the dignitaries who are present here. I would take great privilege. Can I have Sanjeev Kaur sir's CV, please? It is a great honor and privilege for me to. Am I audible? Sir's CV
Yes,
is not. Yeah.
Slightly less.
Sure. Yeah. It's a great privilege and honor for me to introduce Dr. Sanjeev Kaur sir. Sir is a highly respected consultant infertilologist and IVF specialist from Pune with over 3 decades of dedicated clinical practice in reproductive medicine. He is a former president of Pune Obstetrics and Gynecology Society and has served as a coordinator of West Zone for Endometriosis Committee for FOXY, reflecting his long-standing academic leadership. He's also a gold medalist in his MD, and he has set up the first super specialty infertility center at Pune. There are a lot of original innovations and scientific contributions by Dr. Sanjeev sir. Padmasan positioning of patient at laparoscopic tubal ligation. He has patented the the clamp and introduced the Kurtz technique of tubal ligation and also the peritoneal jelly. And he's also spotted Deer sign, a new diagnostic sign for PCOS. And he's author of various publications and presentations, and he's also authored various chapters. And he's a renowned laparoscopic and fertility consultant and specialist, which indeed it's a great honor for us to have him here in this course, and he's going to deliver his teachings and expertise in the topic why women are infertile in endometriosis. The virtual floor is yours, sir. Please.
Can we have introductions restricted to 2 or 3 sentences only, please? Thank you.
Sure, sir.
Madam, thank you so much for your kind words. First of all, my heartiest congratulations to ICOG and thanks to all the office bearers and especially Madam Ramani Devi for getting me into this program. Sure. I'll just go ahead with this.
Make it full screen, sir.
Yes, that's right. Fine. So, yeah. First of all, the topic that Madam has given me is why women are infertile, and I bring you greetings from our IVF center in Pune.
Sir, make it full screen, sir. It is only slideshow mode. Go to the slideshow mode.
Pardon?
Sir, please reshare, sir.
Just
stop sharing and then reshare.
It's a glitch that sometimes happens with older versions of Office. You need to stop sharing, reshare, and then go full screen, sir.
No.
Is it okay?
Perfect.
Okay.
Perfect.
It's okay? That's right.
Yes, sir.
That's right. So William Osler many years ago said that he who knows endometriosis knows gynecology. Well, even today, if William Osler was there, he would have been telling the same thing about endometriosis. Now we know endometriosis is a benign estrogen-dependent progressive gynecological disease in women of reproductive age, which is extremely common. And even Robert Shaw would have said the same thing, which he said many years ago. Yet, however, there is much that is still not understood, and the condition still arouses interest and controversies. Now, John Sampson, whom we call the father of endometriosis, mentioned that endometrium is a functional endometrium-like tissue which is outside its normal location. Emerging evidence says that it is pathologic. The tissue not only persists but progresses. Now, does endometriosis cause infertility? Well, we know 20% of women of reproductive age. Not every woman with endometriosis will experience infertility. This is something that we must understand. But 30 to 50% of women will. The incidence of endometriosis in various studies quoted is again 20 to 50%. So there is an association between the two. Endometriosis and infertility means unclear. So whenever you have the blocked tubes rising out of endometriosis, we know the answer is very clear. But many times the tubes are open, everything is fine, but still the woman does not conceive. And then we don't have clear answers to questions. Well, these are different studies which are nearly 40 years. Well, endometriosis was diagnosed at laparoscopy. It was stage 1, stage 2 endometriosis, minimal and mild. And what they did, they offered no treatment. Nothing was given. And they just observed. And what did they find? That nearly 50% of them women conceived. So this success at pregnancy, remember, is less than what normally one should expect. See, in normal fertile women, the success should have been 90%, but here it's 50%. All that it shows that endometriosis is subfertility. The chance to conceive per month is much lower than the normal 15 to 25% chance. Here you will see from the figures, it's ranging between 1 to 10%. So this is what happens in endometriosis. And same thing they observed for all stages of endometriosis. It has a negative impact. And more severe the disease, lesser is the fecundity. What has been seen, whenever you have minimal and mild, the expectant with expert management, that means no treatment is offered, 50% will conceive. With stage 3, 33%. And at stage 4, the success rate plummets down to as low as 0%, especially when you have blocked tubes, but not more than 1, 2, or 3%. So this is what we must understand, that endometriosis causes subfertility. Now, how does endometriosis cause subfertility? Now, we all know that endometriosis is inflammation. That is the hallmark of endometriosis. Chronic pain is there. The aftermath of inflammation is fibrosis, which causes anatomical distortion. Pain, of course, is the presenting symptom, and there is dyspareunia, which obviously results in sexual dysfunction. The couples may not be able to have relations or proper relations. Proper deposition of semen may not happen, and that could be the reason of their infertility. Endocrine dysfunction, molecular dysfunction are all there, which cause infertility in the woman. So various mechanisms which I have just enumerated affects all stages of reproduction, leading to subfertility, which causes infertility. Now, endometriosis causes a hostile peritoneal environment. There is a pro-inflammatory environment that happens. Various cytotoxic metabolites, substances are produced from the endometric implants or some tissue. These include prostaglandins, inflammatory cytokines, various inflammatory cytokines, which attract macrophages, interleukin-8, and vascular endothelial growth factor. There's an increased production of these in the peritoneal fluids that has been seen in various studies. And all this creates a hostile environment for the oocyte, which is subjected to oxidative stress. There are higher rates of spindle abnormalities. The sperm is also affected. The sperm DNA damage, which reduces, and there is reduction in sperm motility, acrosomal reactivity when penetration is diminished, and this leads to impaired sperm oocyte fusion and reduced fertilization. whose embryo quality is also affected, the embryo cleavage is reduced and slower embryo development. Endocrine dysfunction is seen in the form of altered or defective folliculogenesis. Luteinized unruptured follicles are common with endometriosis, and we all know there's progesterone resistance. So all this prevents a successful ovulation to occur. Now, in all these years, we always felt that all the other steps of reproduction are affected except the implantation. Well, if you see this study, which is about 30 years ago from Pelliker, he mentioned that in women with endometriosis, implantation is reduced. But implantation is reduced not because of the endometrium, but what he said that because of the embryo quality is poor, there's decreased number of blastocysts, increased arrest of embryos that happen at 72 hours, and therefore there is reduction in implantation. Garcia Velasco again quoted a study where endometrial receptivity was analyzed and the pinocchio expression was unaffected. That was the conclusion of their study. And we all know about the egg donation program. It mentioned that a woman who has endometriosis has a good implantation rate. That means the success rate are unaffected in an egg donation program. So all this led us to believe that probably the implantation in endometriosis is not affected. But recent studies, molecular studies have clearly mentioned that there is a dysfunction, failure to properly express the key markers, especially the HOXA10 during the implantation window. And this leads to a prevention of successful implantation in women with endometriosis. So what is important, implantation is also affected in endometriosis as contrary to what we believe. Fibrosis, which is the aftermath of an inflammation. In women with endometriosis, unlike pelvic inflammatory disease, the tubes are rarely affected. This is something that we must know, and they show patency, even in stage 4 or severe degree endometriosis. But we must understand the fibrosis leads to anatomical distortion, and we'll have adhesions and pelvic fibrosis, which distorts the tubo-ovarian relationship for ovum and therefore infertility. And of course, in some cases, the tubes might be blocked, leading to hydrosalpinx, where the chance of pregnancy is absolutely zero. Now, to sum up everything, we understand that because of various mechanisms, the chance for fertility in patients of endometriosis is reduced. Endometriosis subfertility, and therefore the women start taking longer time to conceive, and that is what leads to infertility. From the normal 15 to 25% chance per cycle, it crashes down to as low as 0, especially when the tubes are blocked or the tubo-ovarian relationship is distorted when the ovum pickup cannot happen. But even if the tubes are apparently normal, patent, as I mentioned, during stage 4 endometriosis, the chance, though not maybe as low as 1%, 2%, and it may go usually not beyond 10%. And therefore, these women take longer time to conceive. So this is what are the mechanisms. This is why women with endometriosis find it difficult to conceive, as they would have conceived easily had they not had this disease. So thank you very much for the patient listening. Pradeep?
Yeah. Thank you,
How does
sir,
it
for
go?
your
Thank you, sir.
precise talk. And I request Dr. Vasantara to give a comment.
Thank you, sir, for that wonderful lecture where, you know, the end was endometriosis is subfertility. So I think being gynecologist or fertility specialist, it is the onus on us to understand how endometriosis can reduce the fertility index of a woman. And first, our understanding will translate into patient counseling. So whether it is mild minimal endometriosis or it is going to be stage 3, stage 4 endometriosis, patient symptomatology is one thing, quality of life is one thing, and when a person is approaching for fertility, we have to set realistic goals. And definitely decreased ovarian reserve, as you mentioned, that, you know, even though the chances of pregnancy is maybe 0.1 to 10%, we never write off a woman that she cannot get pregnant with a very low AMH levels, or whether she cannot achieve a natural pregnancy or anything, but definitely it is a wonderful scientific evidence-based talk that we take home from here, and we can counsel patients, and we also learn from this that endometriosis is going to cause subfertility, and we have to be fertility conscious and help the women make some choices of when to take ART treatments or when to do a laparoscopic surgery and clearance that is going to improve their quality of life before ART or after ART. It totally depends on the case scenario. And thank you so much, sir. That was a very comprehensive talk on why women are subfertile. It is a very, very elusive field, but there is definitely some clarity on where we are after your lecture. Thank you so much for that.
Thank you. Thank you, madam.
Can we have the introduction of the next speaker, please? I see Dr. Neeraj Jadhav is already here with us.
Yes, I'm happy to introduce our next speaker, Dr. Neeraj Jadhav, who is well known to us as Chairperson Sexual Medicine Committee. He's Vice President FOXI 2027, and he has many accolades to his record, and he's speaking on a topic appropriate to his interest, that is sexuality in endometriosis. Well, we welcome you, Dr. Neeraj Jadhav.
Thank you, Poonamji, for your kind introduction. Let me share my screen. So at the outset, I would like to thank Ramani Madam, Pratik, and ICOG team for inviting me to talk on a topic that is very close to my heart. And I congratulate them to think about this topic, because we hardly discuss sexual health or sexual dysfunction in our fraternity. So thank you, Madam. So I'm going to talk about the endometriosis and sexual dysfunction. Endometriosis has negative effect on intimate relationships and sexual function. It has negative effect on multiple dimensions of sexual function in affected women as well as in their spouse. For this woman, engaging in sexual intercourse is often for the purpose of having children or to simply to satisfy their partner's sexual needs. Problem related to sexual function and infertility resulting from the disease can cause marital conflict. Facing the symptoms of the disease by causing disruptions in the personal and social life prevent patient from pursuing solution to the problem related to sexual function. So we as a gynecologist need to adopt a comprehensive and multidimensional approach that include medical treatment, sexual counseling, and education, as well as psychological support for women with endometriosis and their partner, so to improve the quality of their sexual life. So coming to the symptoms of the endometriosis, you all know that there is a chronic pelvic pain, dysmenorrhea, infertility, fatigue, bloating, bladder bowel syndrome, as well as there can be sexual problem like dyspareunia, that is the most common. Then there can be reduced desire or arousal. And sometimes there is a often coexist with the anxiety and depression. So while dysmenorrhea is classic, dyspareunia is often the symptom that most disrupt the sexual life and the relationship. Many women don't volunteer sexual complaint unless asked directly, because stigma plays a big role. And comorbid mental health issue also amplify the cycle. So coming to the sexual dysfunction, it is difficulty in desire, arousal, orgasm, satisfaction, or pain during intercourse. There are various tools to quantify the sexual dysfunction. One is the female sexual function index, that is a 19-item questionnaire which cover all the domains of the sexual response, that is desire, arousal, lubrication, orgasm, satisfaction, as well as pain. And also important is the female sexual distress scale. So FSFI is a gold standard. It is a quick, validated, and widely used in the endometriosis research. A score of 26.55 flag dysfunction. In endo cohort, average often fall to 18 to 22. So we should always pair it with the distress scale, because pain alone doesn't require equal to the dysfunction, unless so patient should be bothered by it, or couple should be bothered by about the sexual problem. Then and then only it is a dysfunction. So we all coming to the female sexual dysfunction, it implies that persistence or recurrent problem encountered in one or more stages of the sexual response. It is not dysfunction unless the woman is distressed about it or it negatively affects the relationship. Coming to the current classification of female sexual dysfunction, that is came into 2013, that is the DSM-5 classification. FSD is broadly divided into main three categories. One is the female sexual interest or arousal disorder. Then comes the female orgasmic disorder, and last one is the genitopelvic pain or penetration disorder. So coming to the prevalence of sexual dysfunction in endometriosis, FSD is present in 50 to 79% of the women with the endometriosis. In some of the recent studies, the figure is as high as 76 to 77%. Dyspareunia was found in around 50 to 75%. In this, deep dyspareunia was found in 40 to 55%, while superficial was found in around 43 to 50%. And concomitant, that is a deep as well as superficial dyspareunia, is present in around 43% of the cases of endometriosis. Sexual distress was found in around 65 to 70% of the cases. There is the avoidance of the intercourse leading to the negative cycle. Look at this number. It is up to 79% in some of the studies. A 2024 study showed that 75.7% with dyspareunia and nearly half of that had both deep as well as superficial type. So concomitant is the worst case scenario, because there is a high pain score, there is a worse quality of life, and this isn't minor. It is a major reason women avoid intimacy. So coming to the analysis of the FSFI score and updated meta-analysis of 2023, endometriosis patients have a significantly lower total FSFI and all domain score. Pain is the most common, followed by arousal problem, then followed by desire, orgasm, and satisfaction. Total FSFI is often 18 to 22% in this group of endometriosis patient. And in recent study, mean total was around 18.3. So meta-analysis confirmed that there is a consistent impairment across every domain, not only about the painful intercourse. Mean score hover around 18, well below the cutoff of 18 to 22. That is why we can't assume pain relief alone can fix the sexual problem. Coming to the type of dyspareunia in endometriosis, deep dyspareunia is when there is a pain in the pelvis or vagina while sustained. It is linked to the DIE. Superficial dyspareunia when there is a pain at the vulva or introitus, and there are often secondary problems like pelvic floor hypertonicity, vestibulodynamia, atrophy from avoidance of the sexual activity or due to the hormonal treatment of the endometriosis. Concomitant is the most common, followed by the deep and then superficial dyspareunia. Here is the anatomy. Deep pain hits the lesion during the thrusting. Superficial often develop later on from the muscle guarding or from the disuse of the muscle. In a key 2024 study, over half of the both types said that the deep come first. This progression explained that why many have a mixed pain, that is a deep dyspareunia as well as a superficial pain. So dyspareunia, the most commonly reported symptoms, often described as a deep stabbing pain during or after the penetration. This is frequently associated with the DIE. Then there is a loss of desire and arousal, because chronic pain leads to anticipatory fear of the intercourse, which biologically dampens the libido. Over the time, this cyclical pain result in a decreased arousal and difficulty in achieving the orgasm. So, to understand the mechanism of the pain, it is a multifactorial model. It can be due to the direct mechanical cause like lesion pressure, compression, or adhesion during the penetration. There can be inflammatory cause like cytokinins and prostaglandin, which can lead to the peripheral sensitization. It can be due to neuropathic as well as central mechanism because of the central sensitization, hyperalgesia from the chronic pain. It can be due to musculoskeletal factor like pelvic floor dysfunction leading to the tightness and pain. Sexual problem can also be because of the hormonal treatment side effect, because hormones can lead to the reduced libido as well as a reduced lubrication. Then there can be psychological factors like anxiety, depression, fear of pain, body image, and relationship strain. So basically, there is a cycle. There is a pain during intercourse, which leads to avoidance of the sexual activity, and that leads to the secondary issue in the sexual health. So, the sexual problem leads to the impact on the quality of life and as well as in a relationship issue. There is a reduced sexual satisfaction, intimacy, and frequency. There is a higher sexual distress and avoidance of the intimacy. That leads to the strain on the partnerships. Then there are mental health issues like anxiety, depression, social isolation. So coming to the diagnostic approach, comprehensive history is the most important, using various indexes like female sexual function index. Then we have to do the pain mapping, identifying if pain is superficial or deep. Then you all know about the imaging. Then physical examination is also important to carefully pelvic examination to identify the trigger points or pelvic floor hypertonicity. Coming to the management part, it is always multidisciplinary approach where medical and surgical treatment is the important part, as well as a physical rehabilitation, and also important is the psychosexual therapy. Coming to the hormonal part, you all know that is the hormonal part is the first line of treatment. But whenever you put the patient on the hormonal treatment, problem is that there is a due to hormonal therapy, there can be reduced pain, but there is a limited or no improvement or sometimes worsening of the desire, arousal, lubrication, and decrease in the FSFI score. So surgical approach is the best approach. Evidence suggests that there is a significant after the surgery, there is a significant improvement in the dyspareunia, FSFI domain, and distress at the 3, 6, and 12-month duration following operation. Like FSFI total increases, deep dyspareunia decreases markedly. There is an improvement in desire as well as satisfaction. So for better surgery is the better for always for the concomitant type, independent of the bowel resection. But there is a recurrence risk of 20 to 50% in a long term when related to sexual problem. So surgery science here, studies from the 24-25 shows that there is a meaningful gain in the sexual function after surgery, especially desire and satisfaction domain. Excision address root mechanical cause. Nerve sparing technique helps to preserve the function, but recurrence means a long-term follow-up is a key. Also important is the pelvic floor physical therapy because it relaxes hypotonic muscle, improve tone, lubrication, as well as have a better comfort to the patient. There is a reduce in the superficial and deep dyspareunia after the physical therapy. There is an improvement in the quality of life, improvement in the sexual satisfaction. There can be also some of the adjuvant therapy like vaginal dilator. Nowadays, Botox therapy is there, and also is the topical therapy. So physical therapy is best for the overall sexual function. So PPPT is a game changing for the secondary muscle issue. Recent pilot and RCT shows that there's a reduced pain as well as a better relaxation with the physical therapy. So how pelvic floor physiotherapy helps? The pelvic floor muscle may become hypotonic as a protective response, creating a pain in this type of patient. So this therapy helps to work to relax, stretch, and strengthen the pelvic floor muscles, and improving function and reducing pain without directly treating the endometriotic lesion themselves. There are various physiotherapy modules are available, like there can be manual therapy, stretching and strengthening exercise, biofeedback, education, and there is a transcutaneous electrical nerve stimulation. These are all are the forms of the various physiotherapy which can be available to this patient. Also important is the mindfulness technique in this type of patient, because mindfulness is a conscious state of acceptance, just 2 minutes, and present moment awareness without judgment. It is rooted in the Buddhist Vipassana meditation. How it can help? By focusing on the present moment, it reduces worries about the future outcome during the sexual activity. The non-striving aspect of the mindfulness encourage letting go of expectations and goal, and promoting a more accepting attitude. So, coming to the takeaway, endometriosis causes female sexual dysfunction in 50 to 79% of the cases. Dyspareunia is present in 50 to 75% of the cases. All FSMI domain are impaired. Surgery plus physiotherapy plus psychological support is the most effective for the sexual health. Hormonal treatment is often insufficient alone, because it may worsen the desire and satisfaction. Early multidisciplinary patient-centered care is essential. We should promote the open discussion to reduce the stigma and isolation. So biggest barrier is the silence. So we should normalize this conversation in our clinic whenever we are dealing with the endometriotic patient. So part 2 recovery is always about screening, primary treatment, rehabilitation, and support to this group of the patient. So closing message is the addressing sexual health in endometriosis, improve their quality of life. So always break the silence. If patient is not breaking the silence, we should be more proactive to break that silence about their sexual problem. Thank you. Thank you for your patient hearing.
Thank you, Dr. Neeraj, for such a brilliant description of different issues which can arise in a patient of endometriosis. And very rightly said that it is a holistic approach, medical, surgical, as well as the counseling. And what was really impressive that you have mentioned mindfulness, Vipassana. So it is a holistic approach. And in the counseling, the husband or partner has to be included, because many what happens in clinical practice, that understanding a clinical situation helps them cope, understand, so the partner will be more sympathetic. So all this is a very complex issue, and thank you, Ramni, for including this topic. And once again, thanks a lot all the organizers, Prateek and everybody, and thank you.
Thank you, Dr. Neeraj Jadhav, Dr. Poonam Dikshit. I see Dr. Aruna Nigam is driving. Please drive safe. I will not request you to the other chairperson. Dr. Uma can take care of it.
There is no problem. Dr. Ujjwala is very close to me, and she's a organizer for the National Conference of Indian Society of Colposcopy Cervical Pathology this year in Chennai on 27, 28, 29 March. So she's the HOD of the Adyar Institute. Endometriosis is an invasive disease, but how much malignancy can occur and how to deal in those cases, that Dr. Ujjwala is going to talk on. So over to you, Dr. Ujjwala. Dr. Ujjwala.
You're muted, ma'am. I've sent you an unmute request.
Very good afternoon to all, and thank you to Dr. Prateek, Dr. Ramani Devi, to give me this opportunity to talk on endometriosis and cancer. Thank you, Dr. Aruna, for the kind introduction. So I'll just start sharing my screen. So today's topic given to me is endometriosis associated malignancies. Learning objective for today's, can everybody hear me?
Yes,
We can
yes.
hear you, but we can't see
Yes.
your screen yet, ma'am.
Is it visible now?
We can see your browser. We can't see your presentation. Yeah. Can you go full screen, please?
Yes.
Perfect. Thank you.
Okay.
So today's topic is endometriosis associated malignancies. The learning objective for today's lecture, because all 2 days we have learned about laparoscopy and we have seen so many video lectures, all laparoscopic surgeons speaking entirely doing laparoscopic surgery, removing deep endometriotic patches inside the pelvis, on the ureter, everywhere. So all this dissection, where we lead to, this is the topic we are going to discuss in today's topic. To increase our knowledge about endometriosis and cancer, to understand the updated evidence for screening, new developments on genetic basis, and the risk reducing strategies for the malignancies which happens because of the endometriotic tissues which are left behind, and to inform about the potential novel strategies which are developing in the clinical trial in near future. So definition, etiology in this another last few decades, the endometriosis associated cancer. Endometriosis leads to various cancer. It's a estrogen dependent cancer. So it may happen in breast, it may happen in other parts of the body. The most affected organ is the ovaries. So ovarian cancer is the commonest cancer. And we define endometrial ovarian cancer is if the cancer is present in the background of endometriosis, then it is called as endometriosis associated ovarian cancer. It could be present either in one ovary, the other ovary, or it could be in any part of the pelvis peritoneal cavity, which may lead to the endometriosis associated cancer. Now, whatever the recent updates which are available for this development of cancer because of the endometriosis, it's a multifactorial process. Endometriosis itself is a carcinogenic effect. Genetic changes happen for a long time if the patient is exposed to endometriotic tissue. There is an oxidative stress. Repeatedly 2 days we are talking about oxidative stress. So we'll understand in depth what this causes to the tissues. Significantly increase in cancer because of this endometriosis. If it is for long time, it may increase from 4.2 to 9.7 fold as the age advances. The average age for endometriotic cancer is 48 hours plus minus 3 years. So perimenopausal age group is the age for the cancer. Till now, there are no screening methods. Only endometriomas, which are more than 9 centimeters, can be helped. And pathophysiology is the ARIDA mutation. 60% of the patient have ARIDA mutations and other mutations of the genes like P53 and PICA3C. So we already know about endometriosis. Because of the Sampson theory, there is a retrograde menstruation. There are endometriomas, and these endometriomas have atypical changes leading to endometriotic cancer and clear cell cancer. The commonest cancers are the clear cell cancer and the endometrial cancer. And these are lead because of the inflammatory changes, the oxidative stress, and the malignant transformation. So in endometriosis, when we see the endometriomas have normal cells with lots of hemosiderin that leads to chocolate cyst. And when there is a mutation because of the oxidative stress of the hemosiderin pigments in the ovary, that leads to genetic mutation of the cells leading to ovarian cancer. And this increases 5-folds when the patient is exposed to more than 5 years of endometriosis. Not all patients with endometriosis will have cancer. Only certain cases which all ovaries will not have cancer. Only the few which have These endometriosis associated cancers are the patients, when the genetic tests were done for all the ovarian cancers and all the endometriotic cancer, they found that some genes are common to both the things, for the ovarian cancer as well as the endometrial cancer. So these are the common genes, BRCA1, BRCA2, ARIDA genes and P genes, which leads to endometriotic associated cancer in future. So the molecular pathways which are involved in endometriosis and associated malignancies, basically we'll discuss only the 3 genetic changes which happens. That is the KRAS mutation, 20% of the cases are responsible for malignancy, the P10 mutation and the ARIDA mutation, which leads to clear cell carcinoma. So what are the novel strategies, diagnostic methods to detect for the malignant transformation of endometriosis and its genetic relationship? So when we screen for entire panel of genes, all the genes may not lead to malignancy. There are very few shared genes out of the 25 genes which are responsible for the endometriosis. All the genes may not lead to cancer. Only few of these genes which are responsible for the endometrial cancer or the endometriotic clear cell carcinoma are only these 3 types of genes. Why we have to go into details of the genes is because last 2 days we were seeing only the laparoscopic removal of the disease. We don't understand the pathology of the disease. Why this disease is coming? Everyone is training themselves for removal of the endometriotic patch by doing laparoscopy, training themselves for 10 years, 20 years doing robotic surgery. But if you know the pathogenesis and if you delete the cause by removing molecule from the body, then you don't have to go for this extensive surgery. So we should understand the pathology. So if there is excess of estrogen in the body, that is one of the causes for endometriosis. And if there is any tissue injury to the ovary or the things, then there is release of this tissue necrotic factor. And this tissue necrotic factor is one of the factor which leads to genetic alteration leading to endometrial cancers. So commonest chemical changes, what happens in the cells are the changes in the tumor necrosis factor, interleukins, the vascular endothelial growth factors, to name a few. So to understand the pathogenesis of cancer, which the endometriosis in future changes, it includes the genetic mutation, the changes in the microRNA, and the oxidative stress, what last 2 days we were discussing, all these hormones, everything leads to malignancy. These are the molecular level of changes. We will be concerned only on the tissue necrotic factors, which leads to cancer. To understand in gross how the malignancy happens, how the changes happen from the normal endometriomas to endometrial cancer or the clear cell carcinoma, is the only few genetic changes. Till 1990, when in Planck, we were not having any. But in last 4 or 5 years, we have done a very good research on genetic mutations, and we are able to find out the genes which are responsible for this endometriotic and clear cell carcinoma, which are seen in the background of endometriosis. But still, doing liquid biopsies and doing genetic tests are out of question in today's practice, and only we focus on the routine gold standard for doing ultrasound. And if ultrasound is showing some abnormality, in few of the cases, we may go for MRI and find out the disease. And when the patient comes to us, it's very late stage, and we feel sorry for the patient. So how does endometriosis subtype influence the ovarian cancer risk? This was a paper published in JAMA Network last year, 2024, and it says, as the patient number of years of exposure of endometriosis goes higher, the exposure to the cancer becomes higher. I just want to take you to one case which we have seen. This is the case I wanted to discuss today. This was a gynecologist who came to us. She was a 45-year perimenopausal nulliparous lady. She had previous rounds of infertility treatment. We know endometriosis and infertility, they closely go hand in hand. She had diagnostic laparoscopy at the age of 30 years. She was found to have an endometriotic cyst. For that, ovarian cyst was removed. Some of the ovarian normal tissues were left aside. And then she was given multiple lines of hormone therapies, ovulation induction drugs. In few lines, she was posted for laparoscopic surgery. Ovarian drilling was done for on the right in the course of time, she had 4 times after failure of the hormonal therapy. She was given the course of the treatment for infertility, leading to IVF failure for 4 times, and the patient was very frustrated. So this infertility, IVF, multiple lab surgeries for endometriosis, everything is a due course, how the endometriosis is treated everywhere. Then she had a recurrence of endometriosis at the age of 40 years. She failed multiple lines of chemotherapy, medical therapy for endometriosis. She failed hormonal treatment for infertility. She failed ART. She was so frustrated that she had 5 times laparoscopic surgery for endometriotic resection in different parts. She is a very well-renowned gynecologist. She went to Delhi AIMS. She went to a very reputed institute for the resection of the endometriosis and became very frustrated, and she left the treatment. She was so frustrated. For 10 years, she never went to for treatment purpose for infertility and endometriosis. And after 10 years, at the age of 45 years, her pelvic pain increased and there was recurrence of ovarian cyst and she was helpless. So she gave up on treatment, but because of the pain and the increase in size of the ovarian cyst, she came to our cancer institute and she was diagnosed. When she came to a very well educated, a very well informed patient who has gone to multiple lines of treatment for endometriosis, multiple lines of laparoscopic surgery and resection. And I was very sorry. We feel very sorry for this patient when she comes to us with a stage 3 ovarian carcinoma, where we have to treat her like advanced stage ovarian cancer with chemotherapy and surgery. So this is one of the case I want to discuss. There are n number of cases we come across to our clinical practice where we feel sorry for this patient when they come to us in such an advanced case. So why not curb this? Why not stop this cancer? How to stop this cancer? So for this, we have to answer some of the help what we can get in today's available practices. Whenever the endometriomas are there and whenever you feel any solid mass, any solid component in the mass, we have ORAD scoring also. So any solid component, don't just go and do laparoscopy and remove the ovarian cyst. Just evaluate her for malignancy and we can give her a curable treatment for the ovarian cancer. So these are the endometriotic. Another lady's MRI film, which is 66 years. She had multiple lines of endometriotic treatment and she went into menopause. But the dormant cells in the endometriosis, which were left behind, they went into genetic mutation. And at the age of 66, she presented with this ovarian cyst. And this was a clear cell carcinoma. So when you ask the past history and when you ask the patient had multiple rounds of treatment for endometriosis, so do see for the ovaries and just find out that they don't land up in advanced stage ovary where we are very less treatment to offer. So key finding on radiological imaging is if you see an unilocular cyst with solid component and if the patient gives history of infertility treatment, younger patient, they happen in perimenopausal age group. So these are the patients who have potential for developing ovarian cancers in the womb. So prevention there are no follow-up protocols. When you search the literature, there are no protocols for follow-up of the endometriosis. Only few nice guidelines are there for conservative management and surgical management for endometriotic cyst, clinical detect. So as a society of ICOG, we have to take steps forward to find out some guidelines, to develop some research methodology to curb this cancer. These are all paper quoted in 2025. This is the last year paper. So preventive measures for this is hormonal key prevention. That is, we know OC pills can prevent the cancer by 50% if it is given to a patient for more than 5 years. The mechanism is simple: avoid tissue injury to the ovaries. Surgical options are removing of the fallopian tube, that is called as opportunistic salpingectomy. So if you remove the fallopian tubes, the endometriosis which happens in the peritoneal cavity will stop and that will help us in prevention of ovarian malignancy. The ethical issue and genetic counseling: when the patient has multiple family history of cancer, then we can go for genetic counseling. But genetic tests, as of now, till today, we don't have any genetic test to carry out to prove that this endometriosis will convert into malignancy in future. So this is still a research. So key takeaway point for this is, it's a known fact, it's a proven fact that endometrial cancer and clear cell carcinoma are result of long-standing endometriosis in 40% of the cases. The factors which lead to this is P10 mutation, P53 mutation, oxidative stress. Thank you very much for giving me opportunity and talk about malignancy in this prestigious forum of ICOG. Thank you all. Thank you.
Dr. Poonam, do you want to summarize? Please unmute.
Yes. Thank you, Ujjwala, for such a brilliant and comprehensive coverage of a topic which we, as a practicing gynecologist, we all need to understand. And we have to be aware that malignancy can develop because it's a chronic disease. And we have to be very careful when we are managing the patients in a conservative manner. So evaluation of cyst, as we do by IOTA rules or ORADs, as you mentioned, is essential when we are doing the conservative treatment. Often when treating for infertility, we overlook this part of this potential to develop malignancy. And this opportunistic salpingectomy while doing surgery, when I think it is often done in patients, because when they are going for IVF, the tubes are clipped. So I think removing the fimbria can be another option when we are doing such surgery in patients with endometriosis. And most important is that we have to be aware, although the risk is small. What's the quoted incidence, Ujjwala?
I cannot quote the correct figures, madam, but we do see patients with infertility. I cannot quote for the ovarian cancer, but infertility, endometriosis, when we take a past history, if we treat 500 patients, maybe 3 or 4% patient will be having this clear cell carcinoma with the treatment with multiple line of IVF. I can say it's a iatrogenic cancer. When we do multiple infertility treatment with, there are n number of schedules. There is no proper schedule. If this treatment fails, then they go for infertility IVF. IVF fails, then they go for some other mechanism. So they keep on continuing with experimenting with the patient till she becomes pregnant or she gives up on the treatment.
So this is a very important take-home message, that incidence is pretty high, 2 to 3% in infertile patients. So one has to be aware and vigilant about this. And one more query I had, if I may ask, this unfortunate case which you discussed about the gynecologist, were her previous tissue biopsies negative? She had multiple surgeries, right?
Yes, ma'am, the patient was, I will say our colleague, she was very much well informed. She had the tissue diagnosis and she had the paraffin block of the tissues been revived in 2-3 very prestigious institutes. So a very well-read, well-informed patient who had taken opinion from 2-3 pathological labs with the same specimen, with the paraffin block.
They were all negative? Previous biopsies?
Previous biopsies they were not inconclusive, or she would not have been landed. She would not have been landed in this stage.
Can we move on in the interest of time? We're already 15 minutes late.
Thank you. Thank you very much.
Thank you. Thank you.
So I don't think there's any need to introduce me.
It's my pleasure. Please.
Please, madam. Oh, madam, please.
Yes, next speaker is going to be Dr. Pratik Dambe, who doesn't need much of introduction. I think I can go on talking about his introduction. He's an
No, one line is enough. ICOG secretary. That's enough. Thank you. Let's not stand on ceremony.
Oh, dear.
Without further ado, I would like to begin. Let me begin by thanking the organizers, ICOG, our excellent conveners, Dr. Ramani Devi, Dr. Subhash Malya, Dr. Asha Rao, Dr. Shashika Bras, and everybody who's contributed to the 3 days proceedings. Thank you for having me here. I apologize on behalf of Dr. Madhuri Patil, who unfortunately is not able to join us, and I'm here to speak on her behalf. And my talk is going to be on management of endometriosis associated infertility. This is going to be a slightly large talk. I'll try and compress it within 15 to 20 minutes. So apologies if it's a little boring and it's a little long-winded. Once upon a time, there was this wonderful singer-songwriter called Bob Dylan, and he said, behind every beautiful thing, there's some kind of pain. And I don't think I need to qualify this statement after 2.5 days of academic proceedings on endometriosis. And I think we can also dispense with the initial slides, which question whether this topic is actually clinically relevant or not. We have an HTA guideline, which was published in 2022. And there is a summary paper in Human Reproduction also for those of you who are interested, those of you who are into teaching, or if there are any trainees. This is the guideline that we usually follow. Of course, it's hopelessly out of date now between you and me, and it needs to be updated. And we will see an updated version of the guideline probably in the next 1 to 2 years. Speaking of outdated guidelines, NICE has a guideline on endometriosis, which was published way back in 2017. And somehow this seems to have slipped through the cracks. They've completely forgotten about it. Or maybe it was due for a revision sometime during the pandemic and they have lost the plot. Hopefully that will also be updated. ASRM has lots of wonderful guidance regarding endometriosis in general, also premature ovarian insufficiency and women who are poor responders in particular. But here I want to highlight a couple of important points. Medical management is considered the first choice as per ASRM as far as adolescent endometriosis, chronic pain, and recurrent endometriosis is concerned. And this is effective. That is what has led to a paradigm shift in the treatment of endometriosis over the past decade or so. And you must have seen that from the several different presentations which have been delivered over the past couple of days. However, we forget to mention that whenever medical management takes place, this precludes ovulation and therefore these women cannot conceive. And I have actually come across gynecologists in the interiors who say that I've been putting the patient on Dynogest for 6 months and she simply won't get pregnant. And they don't seem to understand that medical management and infertility are two opposite pathways, and one obviously necessitates that the other is not going to take place. Which brings us to what are the practical management pathways. And we have been saying this since day one, that it takes up to 7 years for women to receive an appropriate and correct diagnosis of endometriosis in the Western world. I don't have an equivalent figure for India because there are no published studies. And for those of you who are into teaching, who are into medical colleges, please go ahead and try and collate your data and publish your data so that this figure can be updated specifically in the context of the Indian subcontinent. My presentation is structured in the following way. We'll talk about the goals of therapy, informed treatment choices, strategic planning, shared decision making, and finally, a little bit of management alternatives, which we can use in clinical practice. It's all very well to talk theory, but it's important to be practical in life as well. And your goals of treatment are going to vary according to the severity of disease. This was excellently tackled by our previous speaker, Dr. Sanjeev Kaur, who has decades of experience in infertility. And some of my presentation is going to overlap with his. Medical therapy has very specific goals, but these goals, as I said a little while earlier, are going to preclude your fertility management. They are not going to enhance fertility in the short term. In the long term, maybe yes, but while she is on the medical management, she's not going to get pregnant. It's very important to have that conversation with the couple. Sometimes couples themselves feel that while they're on medical management, the disease will get suppressed and she will conceive on her own. It doesn't work that way, unfortunately. So when we talk about the pathophysiology, this has been very ably covered by Dr. Sanjeev Kaur. I will just highlight 2 or 3 important points. What we fail to mention is that these women have poor quality gametes. They have lesser number of gametes. They are going to have a lot of completely battered endometrial receptivity, specifically the markers which are important from the implantation point of view, like glycodyline, osteopontin, and hoxatin are all going to be completely smashed. There are autoantibodies. There's a chronic inflammatory process in place. Your interleukins, prostaglandins, all are going to be sky high. This is a very hostile environment for the embryo to actually be created or even implanted. And that's why even in the best of hands, even after ART, the success rates are very low. Just wait for a couple of minutes and we will come to those slides regarding ART specifically. As we said, medical management recruits fertility and fast track treatments, therefore, are the need of the hour, and they will yield you the best results while the disease in its nascent stage, while we are in the early stage, when we have the best quality oocytes and we have the best yield of the oocytes. So specifically, how do you treat subfertility in stage 1-2 disease? Now here, this is usually an incidental diagnosis. That's what we call diagnostic hysterolaparoscopy. Now, this is an outdated concept. It's not something which we do anymore, but certain parts of the country, the interiors, tier 2 cities, villages, they still do this procedure called as diagnostic hysterolaparoscopy, where we follow a see and treat approach. If you see if you see endometriotic implants, you fulgurate them with bipolar. Ideally, you should excise them, but be careful of the ureters. And then after that, what do? After you have removed the implant, does it mean that the patient is magically going to conceive on her own, or does she need some help after that? That is the question which we've been trying to answer for decades. And fortunately, today we have an answer to that. We're not going to talk about the endometriosis fertility index because this has already been tackled by previous speakers. I'm going to skip past these slides. What I will focus on is the fact that this gives you a very good prognostication. In fact, if you have somebody who has an EFI score of between 6 and 10, probably for a few months, you might leave them to their own devices, or you will give them some supportive medication. And what supportive medication you can give them, we'll come to in just 1 or 2 slides. On the other hand, if you have a patient who has a very poor compromised EFI score, let's say between 0 and 5 or 6, then these patients are very less likely to conceive on their own or with conservative management. And these probably need to be fast-tracked to ART, ASAP, irrespective of whether you are able to offer it to them or not. So if you don't have those in your center, then probably you should refer these patients. Don't be afraid of losing the patient. Keep the patient's best interests in hand and shorten what we call the time to pregnancy. Dydrogesterone is a molecule which has been around for about 5 decades, and we have extensive experience of this molecule in this country. And the one overwhelming advantage it offers, specifically in patients of endometriosis, especially stage 1, stage 2 disease, is that you can offer it immediately in the post-op period for a short period of 3 to 6 months. Majorly active treatment like IUI or IVF may not be required in these patients. Excellent pain suppression prevents recurrence. It helps to alleviate your chronic inflammation and take care of your oxidative stress, which we mentioned just a couple of slides ago, are the hallmark of endometriosis, which we often fail to take cognizance of. This chronic inflammation is mediated by interleukins, prostaglandins, TNF alpha, so on and so forth, and all of these are suppressed ably by dydrogesterone. You can either use it in a continuous regimen or you can use it in a cyclical regimen. Both regimens work fine. And the reason they work well from fertility point of view is that dydrogesterone does not stop ovulation from occurring, unlike something like Dynogest. If you give it, obviously it's going to block ovulation and the patient is not going to get pregnant. So for stage 1, stage 2 disease, where you don't want to intervene further, you don't want to fast track this patient to IVF, you don't want to put her on that final common pathway factory assembly line of ART, this is a good wait and watch approach that you can take for about 3 to 6 months. And with the added benefit that later on these patients do conceive, then you will find that the continuation of pregnancy rates are quite high, or ongoing pregnancy rates, so to speak, are quite good because of the immunomodulation that dydrogesterone offers. That's the theory. Does it actually work in clinical practice? I would be very skeptical unless there was good data. And the good point is that we have excellent data. As far as pain suppression is concerned, up to 95% of women have good pain suppression in the postoperative period after having been treated for stage 1, stage 2 disease. And significantly, you will find that the acceptance rates, both for clinicians and for patients, are up to 70-75%. The consolidated evidence furthermore says, if you look at the forest plots, that patients treated with dydrogesterone have much better clinical pregnancy rates as compared to patients who are put on other progestins, which means that this is a very good accepted standard of care for these. The next step is to inquire whether IUI has a role in treatment of these women. And the short answer is yes, but it confers limited benefit. And this was an excellent paper which I found, which was published in June of 2017. And it shows you for patients with unexplained infertility, the clinical pregnancy rates are somewhere around 16%, but for patients with endometriosis, they are roughly around 10%. And for anybody who quotes success rates of 30, 40, 50% with IUI, please take it with a pinch of salt. It's not happening on this planet Earth, not in 2026. You have to counsel the couple and give them realistic expectations. So don't quote 30, 40, 50% in endometriosis with poor oocyte quality, disturbed ovarian relationships, bad tubal motility, and poor endometrial receptivity. You have a perfect storm where your success rates with IUI are going to be abysmal. Furthermore, what are the realistic success rates with IVF? And here we have SAT data. This is from ASRM, published from 2010 to 2013. This is slightly old, but here you will see that the live pregnancy rate or clinical pregnancy rate is best for women who are less than 35 years of age. And here it exceeds 41%. And there's a good cohort of patients, nearly 8,000 cycles that they are looking at, which means that this is very good data. And if you look at the success rates in women who are more than 40, then it's quite sad. It's hardly 10, 11%, which goes on to amplify the fact that the younger the patient, the better the oocyte quality, the less advanced the disease, the better the prognosis, which means that we need to fast track these patients to ART ASAP, which obviously and logically brings us to the question, now what is the stimulation protocol of choice? Now this is not a talk about IVF, this is not a talk to an IVF audience, so I am not going to explain this too much in detail and bore you and flummox you, but there are very good papers today which say that it doesn't matter which is the protocol that you use. For a time, we used to feel that the long protocol with GnRH agonist or the ultra long protocol would yield the best results, would give us better quality oocytes. But today it's been found with comparative meta-analyses that the clinical pregnancy rate and live birth rate, even with the short protocol or the antagonist protocol, is equivalent. The treatment burden is less, the cost to the patient is significantly lower, and it's much more patient-friendly as well. So how do you manage subfertility in women who have stage 3 and stage 4 disease? There are multiple challenges and hurdles. And for those of you who treat infertility patients like I have done for 25 years and I've lost all my hair, I don't look like that person in the first slide that you saw in the CV slide anymore. And that's primarily because I have to deal with a lot of poor responders in today's world. These women have poor ovarian reserve. They require much higher concentration of gonadotropins, longer durations of stimulation, technically difficult oocyte retrievals and embryo transfers. There'll be somebody talking to you about that in a short while. But most importantly, even at the end of all that, you get poor quality eggs, sad embryos, very pathetic conversion to blastocysts. And finally, if you overcome all those hurdles, you then have to deal with the compromised endometrial receptivity. For those of you who practice IVF, I will speak to you in your language. If you've heard of FOI and FORT, both of these are the lowest for women who have endometriosis, irrespective of age. And that is a challenge which we unfortunately have not been able to overcome even today. If you look at the published evidence and literature, the debate of short or antagonist versus ultra long is now being resolved, and it's been shown that both are equivalent. I'll close with 2 or 3 very specific questions, and these are questions which came actually from the audience on the first couple of days. And I've added these slides just at the end so that those questions are answered. The first is, how do you manage subfertility in case of an endometrium? And the guideline is very clear. Unless your endometrium is 4 centimeters or bigger and it is causing pain, surgery is not a prerequisite. You can go ahead and stimulate the patient even if she has a unilateral endometrioma which is less than 4 centimeters. Second, how do you manage subfertility in a woman who has adenomyosis or adenomyoma? Now, this is a worst case scenario. If you've heard of this movie, disaster movie called Geostorm, if you've not seen it, please go ahead and see it. It's how a perfect storm actually happens. Innocuous, step by step, everything builds up. So here, it's similar to that. You have poor quality gametes. You have poor endometrial receptivity. You have deep infiltrating nodules. You have pain. you are going through those deposits when you do your oocyte retrieval. So it's a technically difficult oocyte retrieval. But at least oocyte retrieval is done under anesthesia. When you're doing your embryo transfer, you don't know where the cervix is, what is the angulation, what is the canal, where is your fundus. You have absolutely no clue, even if you have a transabdominal ultrasound transducer there who's helping you. Your oocyte yield is going to be sad. If at all you give adjuvants, they are of questionable value. Good counseling regarding prognosis is essential. Set realistic expectations for these women. And finally, the last photography loss. Finally, your oocyte donation, which is still legal in this country, but many patients don't accept it mentally. Fertility preservation is something which we highly recommend for all of these women. The poster girl for this is, of course, Diana Hayden. And thanks to this gentleman called Masako Oyama, and the other gentleman in that picture is actually myself. 17 years ago, I learned from him the art of vitrification. Thanks to vitrification technology, we are able to freeze embryos and oocytes. And Diana, of course, has multiple children through multiple cycles through her oocytes, which were frozen once upon a time. So I'll close with these beautiful words from 2 millennia ago. I'm sorry. Some things are within our control, but some things are not. We have to make the best of whatever we have, and a timely referral to ART is probably what is going to work best for most patients. Thank you for your patient hearing.
Thank you, sir, for that lovely presentation. And the slides were really very, very informative. And do not treat the adolescent endometriosis patients with surgery. That was one of the key points. And as ART consultants, we all face a problem of endometriosis. I mean, your heart sinks, your heart goes out for those patients where you can't explain to them that pregnancy is going to be very, very difficult with them, but you have to take them through and deal with them. Thank you.
Thank you. Thank you very much. Subhash, you want to thank the chairpersons and the speakers of the first session?
Yes, sir. Thank you very much to all our esteemed speakers, Dr. Sanjeev Koch, sir, Dr. One second, sir.
Neeraj Jadhav.
No, sir. I'm actually in the other side also, sir. In the
You are double booked.
Yes, the question and answer sessions also, sir. So thank you very much to all our esteemed speakers, and also thank you very much, Dr. Poonam Madam, Dr. Uma Madam, Dr. Vasundhara, and Dr. Deep Nigam for this, Aruna Madam for this wonderful session and for chairing the whole thing. I now call upon the next set of chairpersons here. I see Dr. Shashibala Ma'am here. Shashibala Ma'am.
Yeah, sorry to. Thank you. Thank you for inviting me. Yeah.
Thank you, ma'am. Shashimala, ma'am. Thank you very much. Professor Geeta Khanna, ma'am, also is here. Madam, good evening, ma'am, and welcome to the show. Dr. Neeta Thakre, ma'am, I was not able to see her. I hope she's joined. Neeta Thakre, ma'am, are you here, ma'am? And Professor Uma Pandey from BHU, Professor at BHU, ma'am. Thank you very much. And she's also Governing Council member of the ICOG team, ma'am. Thank you very much.
Dr. Uma Pandey wanted to chair the first session because she's on call today.
Sure. Okay, ma'am. So I invite Uma Madam to please take over the proceedings, ma'am.
Dr. Subhash, thank you. And thank you so much to Ramani ma'am. And also thank you to Dr. Pratik, and his lecture was wonderful. I always enjoy it, and I enjoyed it again. So I'm going to invite Dr. Archana Devi, who is MD, MRCOG, and European EFOG and FROM. She, as instructed by Dr. Pradeep, I was listening, only say 2 lines. So I'm going to say 2 lines. She is in fertility training in Milan Hospital, Bangalore, and she's also ICOG fellowship in reproductive medicine. Madam, floor is all yours. Go ahead. Archana, ma'am.
Yes.
She's not able to share the.
I'm not able to share the
Ma'am,
screen.
you are co-host. You can share, ma'am.
Sometimes it doesn't allow 2 sharing at the same time, but now you should be able to.
Yes, now it's coming. Thank you. Is my slide visible?
Yes.
Yes. Thank you, ma'am. Thank you, sir. Good evening to all the delegates present today, and it's my privilege and thank you organizers for giving me this opportunity. So the topic given to me today is FET in endometriosis. So endometriosis is, as we all know, it's a presence of endometrial tissue outside the uterine cavity, and it is a chronic inflammatory disease with extensive adhesions and organ infiltration. It also leads to a major problem with infertility, especially one problem which we are going to concentrate today is about the embryo implantation, which happens in patients with endometriosis and adenomyosis, and what is the cause, how we are going to overcome, and what are the best protocols and evidence base we will be going through this presentation. So the common cause of infertility is distortion of endometrial cavity and of course the ovarian damage and poor oocyte quality and inflammation and impaired implantation. So this is a normal implantation which happens regularly, but you can see it is a very complex mechanism, the involvement of addition, apposition, and so many various stages, which involves various genetic factors, immunomodulators, addition molecules, proteins, which is involved in this process, where, of course, there should be a synchronization of the embryo with the endometrium. So in this process, there is a lot of things which are changed when it comes to endometriosis and adenomyosis. So the pathophysiology will be the altered endometrial receptivity and altered endometrial microenvironment, as sir mentioned already. So the major problem will be the signaling pathway itself and reduce OX10, OXA10, OXA11, and so many genetical involvement also, and also the altered microenvironment, which leads to vascular abnormalities and altered addition molecules. And also this microenvironment changes also leads to chronic endometritis, which is not commonly expressed in patients with endometriosis. And underlying hormonal imbalance, as we all know, it is a hyperestrogenic state. So there is overactivated P450 aromatase, which increases the estradiol, and prostaglandin, which also contributes to increased contractility, which hinders with the implantation. And decreased expression of 17-beta hydroxysteroid dehydrogenase type 2. And also the progesterone resistance itself causes inadequate antagonism of the estrogen. So there also the estrogen is increased. And this leads to altered stromal differentiation and endometrial remodeling, which finally leads to poor implantation in patients with endometriosis and adenomyosis. So adenomyosis is presence of endometrial glands and stroma within the myometrium, and combined with the reactional myometrial hypertrophy causing alteration in the endomyometrial junction, that is that myometrial interface, we commonly call it as a junctional zone. The alteration in the junctional zone leads to poor implantation. Apart from that, there can also be abnormal contractility. This not only affects the implantation, even it affects the motility of the sperms, and this thereby causes infertility. Apart from that, there can be chronic inflammation and overexpressed reactive oxygen species leading to chronic endometritis, and altered PR-ER and decreased addition related molecules, which can alter the whole microenvironment and leading to poor implantation. So knowing about the pathophysiology, what does the evidence say? The evidence strategies which improve implantation in endometriosis and adenomyosis, there can be, you can use some pre-treatment like GnRH analog Dynogest, and even the newer molecules like elagolix, which is coming into market, which also said to be used as a pre-treatment for patients before FET cycles. Medications commonly which we use here is progesterone, which is evidence-based. Other immunomodulatory drugs like low-dose aspirin, low molecular weight heparin, steroids can also be used. And of course, these have certain, they are very controversial when it comes to evidence, but it can be used as an adjuvant. And the other molecules like vitamin D, antioxidants, omega-3 fatty acids, lifestyle modification, PRPs, and all those things improve endometrial receptivity. Again, the evidence is very confusing. The blastocyst transfer and PGD definitely, yes, has a higher implantation potential, and surgical treatment is also reserved in certain cases where, following which the implantation is said to be increased. So these are some of the evidence-based strategies to improve the implantation and also pre-optimize the patient before your FET. So the one thing which we are going to concentrate is frozen embryo transfer. Definitely frozen embryo transfer has an edge over other methods of embryo transfer, like fresh embryo transfer or other protocols. So let's just see what the evidence says. So the evidence for fresh embryo transfer versus frozen embryo transfer. Do we have to go for frozen embryo transfer for all the patients with endometriosis or adenomyosis? And what is going to be the outcome? So this is a very latest paper published in May 2025, and this had it's a meta-analysis, and this paper clearly said that IVF or ICSI for FET has associated with more favorable reproductive outcomes compared to fresh FET strategy in women with endometriosis. And whereas this study showed that in adenomyosis, actually there is no difference in the outcome of pregnancy with FET or fresh cycle. So this was a very new thing. And the current evidence, of course, there is a very limited resources. So they wanted to reconfirm with further studies and further investigations. So I don't know, the expert panel has to say how it is going to be. But generally, they say there is not much of difference, especially when it is fresh or frozen. It helps only in patients with endometriosis and not adenomyosis. While I went through the other paper, which was published little before, that was in 2024, this paper clearly says that the overall study suggests that FET has a higher live birth rates in women diagnosed with endometrioma. So definitely in endometriosis, I think FET, and this study actually, it was a retrospective study, and they have included around 289 women with endometrioma related infertility. And definitely the study had significant numbers of live birth rates when the patients had a frozen embryo transfer. So why we have to think of using FET in endometriosis is there is multiple reasons. The one main reason is to improve the endometrial microenvironment, and this definitely allows us to use some pre-treatment strategies and suppress the hormonal imbalance, and also overcomes the supraphysiological hormonal levels which is going to happen during your ovarian stimulation. But again, in certain patients where there is a poor ovarian reserve and where we have to really balance it and individualize it according to the patient, because if it is going to be a poor oocyte quality, definitely the oocyte is not going to withstand the freeze thaw technique. So in certain cases, we have to really individualize the treatment for the patients. So there is no blanket rule for patients for FET in endometriosis. It has to be individualized. So what are the common protocols which are available? There are like 3 protocols which can be used, and natural or modified natural cycle, HRT cycles, which we are commonly using in patients with endometriosis, and letrozole-based cycles in FET protocols. This is also becoming popular because it suppresses the estrogen activity and improves the implantation. So the advantage of using a natural modified protocol is the patients are less exposed to hormones and reduce complications. And of course, this can be used only with patients with regular ovulatory cycles, and hence the disadvantage be frequent monitoring. How about the HRT cycle? It's very flexible and less frequent monitoring, but the disadvantage is risk of reactivating the disease. Even certain studies say even exposing them to estrogen to even 1 cycle, it's going to have the disease back. So that is one thing. And the letrozole-based cycle can be a good alternative in these patients where there is a hyperestrogenic state is suppressed with letrozole. So these are the 3 protocols, and let's just see what the evidence says in regards to these protocols. So this paper is published in 2025 July in Fertility Sterility, and they have studied the outcomes of program versus natural cycles for FETs in patients with endometriosis. And the implantation of these embryos in fresh transfer were reduced by 15 to 18%, but are restored in a program cycle, suggesting women who basculate late may fall into a tail of window of implantation with consequent reduced implantation rate. So the natural cycles had one disadvantage: they could not tail the patients for in that window of implantation. And if you check the outcome of this study, the authors did not find any difference in live birth rates comparing programmed or natural FET cycles, and the live birth rates were similar when the cycles were used, and they mostly used the cycles to PGTA cases and freeze only cases where where they have done the program cycle compared to the natural cycle. And the embryo transfer in endometriosis. So the pre-treatment with GnRH agonist followed by FET. And this is one of the common techniques or protocols most of our clinicians which we are practicing. So the evidence definitely is for the pre-treatment because it induces pituitary suppression and decrease circulating estrogen. GnRH agonist may reduce concentration of peritoneal metamyeloproteinases, that is inhibitors, and downregulate the inflammatory cells, and also promote apoptosis and expression of pro-apoptotic proteins. And adenomyosin, it reduces the aggregation of macrophages, and hence there is a better implantation rates in patients who are pre-treated with GnRH analogs. And in regards to the evidence, this paper also had suggested that prolonged use of GnRH agonist before IVF ET in patients with endometriosis resulted in significant higher ongoing pregnancy rate and compared to the normal patients who didn't receive the GnRH analog. So definitely GnRH analog usage as a pre-treatment prior to FET has some approved evidence over patients who are not exposed to GnRH analogs. So now coming to the key factors or details in patients with GnRH analog pre-treatment. So the to combat the lower implantation rates associated with the endometriosis related inflammation, the protocol is to downregulate. The commonly used drug is the decapeptyl. And what is the duration? At least minimum of 1 to 3 months should be used, and then estrogen has to be used for the endometrial preparation. The studies have suggested improved live birth rates compared to conventional hormone replacement therapy. And the application specifically works for patients with adenomyosis and those who had previous implantation failures. So now coming to the features of adenomyosis, there are some predictors which we have to check during the ultrasound before we plan the patients for FET. So just doing the ultrasound and diagnosing adenomyosis might not suffice for patients. We have to look into detail about the junctional zone. If the junctional zone thickness is more than 12 mm, if the uterine volume is more than 150, if there is a diffuse adenomyosis, that is, we call it as a globular uterus, if there is presence of myometrial cyst, especially close to the junctional zone, asymmetrical thickening of the uterine wall. These are some of the predictors of poor implantation. So this has to be checked when we do an ultrasound for a patient, and this has to be optimized to some extent before planning a frozen embryo transfer. So the features specifically, if you see, the junction zone more than 12 mm decreases the implantation rate by 40 to 60%, and the volume more than 150 decreases the clinical pregnancy rate. Diffuse adenomyosis again decrease implantation and live birth. Myometrial cyst, surprisingly, it's associated with increased miscarriage rates and implantation failure. And severe adenomyosis also causes implantation failure and recurrent implantation failures. So the pre-treatment with GnRH analog also has reduced miscarriage in patients, especially if the uterine volume is reduced below 100 centimeter. This is a paper which is published in the PubMed. It is also, I think it's a recent paper, if I'm not sure. So this paper also concluded definitely GnRH analog reduces the miscarriage rate, and the volume is ideally below 100 is helpful, and it also prevents recurrent implantation failure. So in patients with recurrent implantation failure, the ovarian volume, if it is more than 100 centimeters, definitely pre-treatment with GnRH analog should be used. And what about the other drugs for pre-treatment like Dynogest and other drugs? So Dynogest also can be used. It's 2 mg daily for 6 months after removal of the ovarian endometriomas in infertile women undergoing IVF. And there is a lot of studies which showed that the clinical pregnancy rates and live birth rates increased 2.5 to 3 times higher compared to those who had no pre-treatment. And however, another study also indicated the decrease in number of oocyte retrievals and embryos compared to the control. So this has to be kept in mind because it downregulates, and because of which there can be oocyte retrieval. So they have suggested a washout period before you stimulate the patients with GnRH agonist. And what are the benefits? Now coming to letrozole-based protocols, what are the benefits is to reduce estrogen effect, that is an aromatase inhibitor, which improves implantation and better outcomes, especially in adenomyosis. But the evidence, there is no significant difference in the clinical pregnancy rates between the letrozole ovulation and other programmed regimens for endometrial preparation. And however, letrozole regime required a simple luteal support, making it favorable protocol for endometrial preparation for FET. Sorry, this is in PCOS patient, but generally letrozole is also being used in adenomyosis as well. So the pre-treatment IVF GnRH antagonist in patients with endometriosis, this is a very recent trial. It's in the phase 3, and the elagolix as a pre-treatment of 200 milligram BID versus placebo is being studied. And the phase 3 trial is ongoing, and the results are yet to be published. But I think some of us are still using elagolix 200 as a pre-treatment for our patients prior to FET cycles, which we are also getting good results with this drug. So surgical management when it is indicated. Endometriosis detrimental effect on infertility and including negative impacts on oocyte, tubal and endometrial function. So laparoscopic surgery for endometriosis elevates both spontaneous and ART pregnancies. And there are some specific indications where we can do surgery prior to FET. So the strong evidence suggested distorted endometrial cavity and adenomyosis close to junctional zone less than 5 mm and recurrent implantation failures, associated cavitary lesions, difficult access of ovaries for oocyte retrieval because of additions. If the patient has severe pain or suspicion of malignancy, these are some of the strong evidence for surgery prior to your FET. And of course, endometriosis fertility index will help us to identify which patient needs early a diversion to ART or which patients have a good prognosis following the surgery. So the goals before FET is suppress inflammation and ectopic endometrial activity, improve progesterone responsiveness, optimize endometrial thickness and receptivity, reduce uterine contractility, especially in adenomyosis. And FET in endometriosis, the expected outcome after optimization, that is, if there is the treatment is not optimized and the patient had an ART, the implantation rate was only 10 to 20%. But usage of GnRH agonist pre-treatment had increased the implantation rate to 40 to 60% and also significantly improved the live birth rates. So if you look at the summary of clinical approach, first diagnosis is the key here. So diagnose the patient with ultrasound or MRI, and ultrasound. With the advancement of 3D ultrasound nowadays, we are able to pick up adenomyosis, and all the mentioned indicators should be seen before you optimize your patient for a frozen embryo transfer. And downregulation with GnRH agonist 2 to 3 months is minimum preferred. An alternative to Dynagest or elagolix, where there can be extended treatment even up to 6 months, should be used as a downregulation before your FET. And endometrial preparation, the best protocol is HRT, and blastocyst transfer with PGTA increases the outcome of positive pregnancy and strong luteal support. So this is the best clinical algorithm according to the evidence. But of course, we have to individualize the patient-based treatment. So minimal endometriosis, still the evidence says that natural cycle FET can also be preferred, and moderate to severe endometriosis, downregulation with HRT. Adenomyosis, if it is mild, 1 to 2 months of GnRH agonist plus HRT. If it is severe, minimum 3 months of GnRH agonist is needed. And estrogen-sensitive patients, letrozole and FET cycles can give us a better result. So customized protocol is one, and individualized treatment according to the patient's clinical condition is the key for successful outcome. And FET is superior to fresh embryo transfer in endometriosis, and GnRH agonist pre-treatment improves implantation and live birth rates. Correcting the cavity pathology before FET is must, and adenomyosis significantly reduces the implantation. So diagnosis and management improves outcome. And blastocyst transfer with HRT protocols gives the best outcomes. So customized FET protocols for patients is the need of the hour. And thank you so much for your patient listening.
Thank you, Ashna ma'am. That was wonderful. And I would like to apologize to Ramani ma'am, Pratik, and also Sheila ma'am that I was on phone. It was a call from labor room and it took a while. So I missed quite important bits of your lecture. I did miss actually, but it was wonderful. You delivered them so well, and the narrations were so nice, and the guidance of doing this with adenomyosis and endometriosis was wonderful. Many people in India, they do ART, and many people do, but there are still neglected people who do not. So for them, I think it would be nice because we are in government sector, we don't have the facilities yet, so we are not doing it. So for us, for us, it would be something very novice, something very new, and I learned it. Thank you so much, and congratulations.
Thank you, ma'am. Thank you for the opportunity.
Congratulations, Archana ji. You spoke so well and you analyzed, and your summary was absolutely okay. I do agree that it has to be individualized, and the way you use it, especially to increase the success rates, that was wonderful.
Thank you so much, ma'am. Thank you.
So shall we move to the next speaker then?
Madam, can I introduce the next speaker? I have to catch
Yes,
a train
please.
at 8 o'clock.
Yes, Dr.
to
Shashi Bala,
Bhopal.
please go ahead.
Yes, thank you. Now, next speaker is Dr. Professor Chitra Thayagraju, and she's fellowship in reproductive medicine and minimal access surgery, and she's from Jawaharlal Institute of Postgraduate Medical Education Research, Pondicherry. So, I invite Dr. Chitra, please, for your deliberation. Can I
thank
see
you,
her?
ma'am.
Yes, yeah. Over to you.
Okay, thank you, ma'am. Thank you, sir. Thank you for the opportunity. Today, I'm going to present the topic on adenomyosis coexistent with endometriosis. Everyone knows both are estrogen-dependent tumors. The symptoms are similar. We have to know whether they have the same pathogenesis, physiology, or is it a different? So we know that adenomyosis is a presence of rest of endometrial glands and the stroma within the myometrium, which might result in the hypertrophy and hyperplasia of the surrounding musculature. And it affects around 20% of the women in the reproductive age group, which includes 22% in the infertile women. And first, before it was telling a disease of the multiparous, now we are seeing many younger patients coming with adenomyosis, and especially patients who are undergoing ART. Endometriosis is a presence of endometrial glands and stroma that occur outside the uterine cavity. Usually it is in the pelvis. The most common is the ovary side, and other multiple sites like bowel, diaphragm, pleural cavity is also been inward. So we have seen that there are multiple types, 3 types of endometriosis. We have seen that 40 to 80% of women with chronic pelvic pain are known to have a pelvic endometriosis, and even the variation of the infertility patients, like 2 to 75% of infertile women also are known to have a pelvic endometriosis. The major culprits of both the diseases are the ectopic endometrium, which are the same for both of them, but the locations are different. So the ectopic rest of endometrial glands and stroma is quite inflammatory. It is estrogen dependent and always progesterone resistant. So coming to phenotypes, we know that there are 2 different phenotypes of adenomyosis. One is this, I think slides are jumping. Diffuse or internal adenomyosis, which is seen in patients, young women, nulli gravida, and is associated more with endometriosis. And we have a focal or external adenomyosis known as FAO, that focal adenoma for outer myometrium, which is seen in older multiparous previous uterine surgery and heavy menstrual bleeding. Though we have seen that comparison, they found that both are having the same symptom of heavy menstrual bleeding, and there was no difference in the pain scores between both the groups. Phenotypes, we already know the phenotypes in patients with endometriosis. You have a peritoneal endometriosis, you have a ovarian endometrioma, and you have a deep infiltrating endometriosis. So let us know what is association. How many patients with adenomyosis we have endometriosis? How many patients with endometriosis have adenomyosis? So in one of this patient with endometriosis, diffuse adenomyosis was seen had a significant correlation with endometriosis, like superficial peritoneal endometriosis was seen in 20% of the patients, ovarian endometrioma was seen in 45%, and deep infiltrating most commonly associated with 35% in adenomyosis. And when you go for the focal adenoma of outer myometrium, it was significantly associated with superficial endometriosis in 7.5, ovarian endometrium 19%, and deep infiltrating is more, which was statistically significant. And both conditions are associated with fibroid uterus 50%, polyps in 2%, hyperplasia in 35%, and carcinoma in 2%. That is adenomyosis. And we've seen the endometriosis also have a high risk of 1.35 times of higher risk of associated with endometrial carcinoma, and it is seen in patients with leiomyoma and 50 to 60% in cases with endometrial hyperplasia. So this also shown that association is similar with the risk of hyperplasia or endometrial carcinoma. When you see the both have an ovulatory cycles which is responsible for them to have these conditions. When we see that ovulation, whenever the patient have a regulatory menstrual cycles, there's invaginal soma, that is a retrograde menstruation, which will go and deposit in the endometrial cavity. From the endometrial cavity, it goes in the peritoneum. In the peritoneum, it occurs deposition on the peritoneal cavity and lead to the release of the inflammatory mediators, which will lead to the survival growth and inflammation. And the same thing, whenever the patient is having menses, there's invagination of this endometrium, that is basal endometrium, into the muscular endometrium, and that also leads to the release of these estrogen receptors, which also leads to the survival growth and more inflammation. So we have found that this both the repeated episodes of ovulatory menses are essential in the pathophysiology of both endometriosis and adenomyosis. The diagram, and any drugs which inhibits the ovulation can be used for the treatment of endometriosis and adenomyosis, like both GnRH, OCPs, high dose progesterone can be used in both. That also shows that similar treatment. But when you see the risk factors, we see the risk factors in adenomyosis. Now it is a multiparous. Now it is more common nulliparous also. Post-uterine surgery, postpartum endometriosis, patient with pregnancies, uterine trauma, or patient with older age. But endometriosis is a disease of nulliparous, more common in the nowadays younger age patients also, and early age of menarche, shorter menstrual cycles. So we have seen that the different risk profile and the different age-specific incidence between the two diseases indicate they are likely to have different pathogenesis. So when you see the pathogenesis, we know the pathogenesis of adenomyosis is that TIR, that is tissue injury and repair, and metaplastic theory, whereas the main theories in endometriosis is coelomic theory, implantation theory, and combination of all of this. The Sampson retrograde menstruation is the most widely accepted. Now if I see in the diagram, can you see there is an intrinsic adenomyosis, extrinsic adenomyosis, and focal adenoma, and whenever there's a retrograde menstruation of this endometrial glands and stroma, it leads to deposition. From there, can you see that big deposition can lead to ovarian endometrioma, or it can lead to the implantation in the peritoneum, that is superficial endometriosis, and it also leads to extrinsic adenomyosis. That is a implantation theory. Whereas you go to the invagination theory, that which is also applies for this endometriosis, it also plays in adenomyosis, where the invagination of this basal endometrium occurs from the basum to the myometrium. So this has the pathophysiology, the theory what is there in endometriosis is also similar to that of the adenomyosis. And when you take the concept, there is the uterus is composed of two phytogenetically and ontogenetically different organs. Here can you see in the diagram that is known as the orchimetry and the neometra. This the blue color what you see is the neometra, which is non-mullerian in origin and exhibits constant eye receptors of the steroid hormones throughout the cycle. Whereas can you see the red color? This is the archimetry, which consists of endometrium, subendometrial unit called junctional zone, and the underlying stratum subvascular myometrium. And they have a cyclical pattern of steroid hormone receptor how occurs in the different phase of the menstrual cycles. And when you take these two theories, we know the peristalsis is very important for any for some sperm transport and causing the fertility. In patient with adenomyosis, what happened? This uterine peristalsis is exhibit hyperperistalsis. As a result, this hypermotility of the sperm, it can lead to infertility. And the genes which is seen, that is also similar to that of the endometriosis, which can abruptly causes the sperm transport inhibition and also can lead to infertility. And when you go to the genes involved in estrogen biosynthesis like STAR genes, P450 aromatase, even these are upregulated both in adenomyosis and endometriosis. And we take the estrogen receptors or any release of secondary to that COX receptors, and which is involved in this tissue repair and the inflammation is also upregulated in both adenomyosis and endometriosis. So this is a pathogenesis which can occur both in endometriosis and in the adenomyosis. Mostly in adenomyosis, whenever there is a trauma to the uterine cavity, that is microtraumatization, tissue injury occurs. As a result, there is increase in the COX, this increase in the P450. That may causes increase in the conversion of the testosterone to the estrogen. So increase in the estradiol occurs, and that increases the estrogen receptors alpha and beta, which plays an important role in angiogenesis, neogenesis, and survival of this endometrial glands and stroma in the ectopic places. Coming to the clinical accepts, we found that the mechanism is more in the retrograde menstruation, implantation of the abnormal oligoclones of the endometrial cells on the peritoneum or the ovary in case of endometriosis. In adenomyosis, we have seen there's a disruption of the endometrial junction zone, which is followed by the invasion of this oligoclonal endometrial cells from the endometrium into the myometrium. And the pathology is mainly endometrial glands and stroma epithelial cells, which is seen in the evidence of bleeding. When you see the pathology report, you can see the endometrial glands and stroma in the histopathology. And even when you see the steroid response, there are more response to estrogen progesterone, but adenomyosis are very less response to estrogen progesterone. And presentation are typical. The symptoms are typical in both the patients having the heavy menstrual bleeding, dysmenorrhea, dyspareunia, and infertility. This one of the study which I've seen that even that the presence of mutations, one of the study I've shown that their endometriosis adenomyosis, they exhibit more than 40,000 somatic mutations. And of this various mutation, you have seen the CRAS. This CRAS is one of the mutation which is seen in the normal ectopic endometrium and even in endometriosis. And this PIK3CA mutations, which is also seen in the ectopic endometrium and endometriosis in the same patient having the endometriosis. But these are the two things which is similar in patients with adenomyosis or endometriosis. But when you compare with the same thing with the fibroid uterus, one mutation, that is MET12 mutation, it is seen more in leiomyoma patient but not seen in endometriosis and adenomyosis. So though this adenomyoma or adenomyosis occur in the outer myometrium, and even the fibroid uterus can also occur in the myometrium, but the genes are expressed differently. This is also one of the reason to telling that they have a similar even oncogenic mutations also. So when we have seen that they have similar symptomologies, both are estrogen dependent, they share many molecular aberrations, and clinical treatment are almost similar. What are the drugs we use are mostly interchangeable, and both have a similar changes, but none of them are permanent curative. There can be reduced symptoms, but most of the time it is recurrence, and they need a recurrent surgeries or change of the medical management. And the classification system also is not, they both need a good classification system, because every time new classification systems comes, and it is have some drawbacks of each classification systems. So why it is very important of identifying this adenomyosis coexisting with endometriosis. So 1 minute, I just my battery is low. I just connected to the charger. So why it is very important for us to diagnose that adenomyosis goes to endometriosis in some conditions where even the endometriosis has been treated, there was persistence of dysmenorrhea and non-menstrual pain also will be there. So it's very important for us to diagnose because I've shown the association of adenomyosis endometriosis. Whenever there's adenomyosis, look for the features of endometriosis, and whenever there's endometriosis, look for the features of adenomyosis. Sometimes the subtle, even the junction zone more than 11 millimeter on preoperative MRI could raise a suspicion this patient can be having a simple hyperplasia or can be going for the diffuse adenomyosis. So subtle anomalies of the junction zone, this is very important. This is one of the feature which can tell the patient can be progressing to the pelvic endometriosis. And if it is there, these are the patients who are more prone to have a poor reproductive outcome. So whenever you have an endometriosis, look for the junctional zone, and junction zones will tell us whether this patient is going to have a simple hyperplasia, diffuse hyperplasia. So how we are going to diagnose this adenomyosis? One is a main thing, we can take 2D ultrasound, 3D ultrasound. These are the features which can be confirmed by the MRI. With junctional zone more than 12 millimeter, normal is around 8 mm. Anything more than 8 to 12 is simple. More than 12, it comes as a patient having a diffuse adenomyosis. And the ratio of junction zone maximum to the myometrium should be more than 40%. And the difference between the maximum and minimum thickness is 5 millimeter. And the modification, there's a hypertrophy, hyperplasia of the myocytes, which is a diffuse thickening or the focal thickening, which we see in the myometrium. And when you do the MRI, you find a high signal foci within the areas of low signal intensity. And linear striations in arising from the basal endometrium going up to the myometrium. And in a patient who are having focal adenoma of this outer myometrium, the DI is more common compared to the other types of endometriosis. This is a MRI picture where you can see the junction zone is thickened and this have a focal adenomyoma. And this is a patient, the second pic where you have a fibroid uterus along with the diffuse adenomyosis. And here you can see this junction zone is 5 mm and you see the other picture where the junction zone is more than 12 mm. This is association of the diffuse adenomyosis along with this DI, where you can see in the rectovaginal septum. So how do you classify simple hyperplasia? When the zonal thickness is 8 mm, 8 to 12 mm, that is simple junction zone hyperplasia. Diffuse or partially diffuse adenomyosis, when the junction thickness is 12 mm. Adenomyoma is a myometrial mass with a indistinct margins with a low signal intensity. So this is one of the studies which I found when I did the MRI. They found the prevalence of endometriosis and adenomyosis. When the junctional zone is more than 8 mm, the incidence of endometriosis is 75%. When it's 10 mm, it is 77%. When its junction zone is more than 12 mm, the incidence of endometriosis was found in 78.6%. When the patient with endometriosis was there, and they found that when the patient had endometriosis, they found that the prevalence of adenomyosis, if the junction zone was 8 mm, was 92%. If it is more than 10 mm, it was 78%. If it is more than 12 mm, it was 58.9%. So they found that endometriosis, visual adenomyosis was around 54 patients had out of 67, and visualized adenomyosis was seen in 51% of patients who are out of 56. So this is the ultrasound imaging, what I have already mentioned about adenomyosis in the MRI. So this is the typical features where you have a asymmetrical uterine enlargement. It's a globular uterus and there is a heterogeneous myometrial texture. And what I mentioned, we can see that linear striation, not necessarily you have to have an MRI. When you're doing ultrasound in the patient with endometriosis, if you see it properly, you can see this linear striation. This is one of the signal that patient can be having an adenomyosis. When you do the sensitivity with 3D and the MRI, they've shown that the transvaginal ultrasound has more specific of 81%, but MRI is having more specific compared to that of the ultrasound in when you differentiate between the adenomyosis and the fibroid uterus. And this is a 3D images where you can see the diffuse adenomyosis, and here you can see the focal adenomyoma, which is the intrinsic focal adenomyoma. And sometimes you can, while doing hysteroscopy for some other reason, when you find these features, you can think the patient can be having adenomyosis, like irregularly enlarged cavity. You can see the wide displacement of the cornea. Sometimes you can see the endometrial defects at the fundus of the uterus. Hemosiderin deposits can be seen, and gland-like, bread-like openings can be seen, which are all the high suspicion that patient can be having an intrinsic adenomyosis. Coming to the management, what are the management whether you take for adenomyosis or endometriosis, I think which has been discussed in detail. You consider age, the reproductive status, the associated comorbidities, whether they completed the family or not, and whether the both are coexistent with the endometriosis and adenomyosis. What are the treatment you're going to take? The first important thing in both the condition is to relieve the pain and the heavy menstrual bleeding, mainly to disturb the pathway which may lead to the excessive pain like inflammation, neuroangiogenesis, and impaired apoptosis. And we already know the first line is the NSAIDs followed by OCPs. You give the GnRH. GnRH is a treatment where you can give both in endometriosis also and can be given in adenomyosis. Both causes profound hypoestrogenic amenorrhea, this GnRH. So when you're giving for more than 3 months, always you have to give the low dose OCPs along with that. And recurrent post-op is reduced only even though you do surgery for this patient, adenomyomectomy or endometrial cystectomy, at least post 3 to 6 doses should be given to prevent the recurrence. And progesterone also can be given in both the patient. It has shown to deserialization of the endometrium. It causes inhibition of the mitosis and also blocks the MMP receptors, which suppresses the angiogenesis and also suppresses the growth factors, endometrial growth factor and vascular endothelial growth factors. Dynogist also has been used in both the patients, which has an effect of decreasing the cell proliferation, differentiation. It has an anti-angiogenic effect. It has an immunomodulatory effect, anti-inflammatory effect. So it can be used in both the patients. LNG IUCD also have seen that we know that it causes residualization and atrophy, and it is one of the studies shown that LNG is safe and effective and promising of both with adenomyosis and endometriosis. So sperms also has been used and both in patients with endometriosis and adenomyosis, and it has been quite effective in relieving the pelvic pain associated with both these conditions.
Dr. Chitra, you will need to wind up, please.
Yes, sir. I have 2 more slides, sir. So
Thank
what is
you.
the impact of adenomyosis and endometriosis upon infertility treatment? They both have a high miscarriage rate and in decreased implantation rate in women with adenomyosis compared to that of these other normal patients. And the implantation rate, clinical pregnancy rate, and even ongoing pregnancy rate, all decreasing patients with adenomyosis and miscarriage rate are increased. And even as this patient conceive, their high risk of miscarriage, placenta-previa, preeclampsia, malposition, LSA. So we have to counsel the patient. Whenever you do the surgery, there can be increased risk of rupture uterus will be there. So we should be counseling the patient. So in summary, I like to tell that adenomyosis, endometriosis are sister entities, and repetitive episodes of ovulation and menstruation are indispensable for both the conditions. And even activating somatic mutation in GRAS have encoded as a CREAT events in both these endometriosis and adenomyosis. Both have a negative impact on the reproductive outcome. So there are higher incidence of complication which can occur in this patient. So proper counseling is necessary. Thank you so much for this opportunity. Thank you, ma'am.
Thank you, Dr. Chitra. It was really all cobwebs got cleared, and your MRI images were very, very, like, you could see to it. So very well explained. Thank you so much.
Thank you, ma'am. Thank you, sir.
Yeah.
Thank you, Ramani, ma'am.
Yeah.
Nice presentation, Chitra. Very
Thank you,
crisp.
ma'am.
Dr. Shashibala, you want to do the honors? Please go ahead.
Yeah. I would like to introduce Dr. B. Kalpana. She's our next speaker. She's chairperson, Foxy Infertility Committee, and gynecologist and fertility consultant at Guru Hospital, Madurai. And she's also course director for postdoctoral fellowship. And I think I need no telling. Shall I read her all academic profile? Kalpana?
Not really needed.
Yes. I know my
Shashibala.
heart. That's why I don't have to read it also.
Yeah.
Over to you.
Yeah. Thank you, Sasibala, for the kind introduction. First of all, I would like to thank, it is always my privilege to be with Ramani Madam. I've been traveling with Ramani Madam for the past 2 decades, starting Queen of Endometriosis as a zonal coordinator, starting from her tenure as chairperson. It is always a pleasure to be associated with you, ma'am. And this workshop is done under the leadership of Foxy President Bhaskar Palser, Secretary General Swarna Kadilkar ma'am, and also Dynamic ICOG team, Sheila Mane ma'am, ICOG chair, and Dr. Pratik sir, Dynamic ICOG team. We could see many programs in the last 2 months. It is always my pleasure to be associated with ICOG and coordinators. We have all experts from endometriosis and endoscopy team, Ashara ma'am, Kanti Bansal ma'am, Dr. Malaraj, Subhash. All experts are here, I think. So let me go to the topic proper. The topic of discussion is oocyte retrieval in endometriosis. Shashibala, can you see my slide?
Yes. I can very well.
Yeah. Oocyte retrieval in endometriosis, is it different? So always endometriosis remains an enigma because the symptoms do not correlate with the severity of the disease, and sometimes it is difficult to diagnose. That there is a delay in diagnosis almost for 7 years, and then in general population, even though the incidence is almost nearing 5%, in infertility it is 10 times higher, almost 50%, and if a patient has got endometriotic cyst, no gynecologist can miss endometriotic cyst because it has got a typical sonographic picture, and so definitely before IVF we can plan our protocol and procedures. Only in advanced endometriosis, if it is bowel or bladder involvement, we need to go for advanced endometriosis. Obviously, when you want to choose a patient, sitting in your OPD, endometriosis would be the last choice because it has got the least pregnancy rate with simple treatment. Fecundity rate in normal couple is 20%, but in endometriosis patient, it is significantly reduced to 1 to 3%. So many a times in minimal and mild endometriosis, we do go for conservative management, sometimes endoscopic management, but in stage 3 and 4, especially if she is elderly and if her ovarian reserve is reduced, or sometimes even in minimal and mild endometriosis, if the patient had not been responding to your simple treatment, then the next line of management is ART. Obviously, if a patient has got tubal factor or severe male infertility, these are all the patients who are going for IVF. So the next dilemma is we are really worried about the huge cyst. Before going to ART, are we going for laparoscopic surgery to remove endometrioma so that during egg collection it becomes an easy job? But we all know that when we go for cystectomy, obviously we are going to do mild damage even in expert hands. It has been proved that in operated ovaries, not only spontaneous ovulation is reduced, AMH is reduced, but ovarian response is also reduced. But obviously, if it is really small and if we feel that it is not going to interfere, we are not supposed to touch the ovaries, because obviously each surgery will reduce her reserve. So surgery should not be the option always. It has got a specific indication, and this is a argument given by various authors because the presence of endometrioma may interfere with ovarian response because it's a space occupying thing which may interfere with the oocyte competence. That was the argument given in 2017, and there is a possibility of higher pelvic infection according to an author published in 2015. Obviously, when we touch the cyst and accidentally enter into the cyst, there is a possibility of pelvic infection. Not always, and pregnancy outcome could be affected. That was the conclusion from Fernandez in 2009. Missing occult malignancy is a very rare remote possibility, but all these expected complications are very rare possibilities. So all these justification would not prompt us to go for surgery before IVF. So the protocol, I think it must have been discussed. Recent evidence says that it could be either long protocol or ANTAG. ANTAG is equally giving a good response and pregnancy rate. And if at all, if you want to go for analogs, it should be a single shot and then going for this one. So obviously, what are the complications we encounter during oocyte retrieval? The oocyte number is significantly reduced in these patients because ovarian reserve is reduced in these patients, not only because the endometriosis disease itself damages the ovaries, but also because of previous surgeries. Sometimes because of adhesion, the ovaries are adherent to the posterior surface of uterus, and sometimes it may be difficult to reach the ovary. Sometimes we'll be missing some of the follicles intentionally. So these technical difficulties, because of all these problems, there is a possibility that we have reduced oocyte yield. And obviously, oocyte retrieval is more complicated in women with ovarian endometrioma. So transfixation is also needed in some of the patients. It is actually transfixation is voluntary decision to pass through endometrioma with a needle without aspirating in order to aspirate the follicles which are located behind. So if we have a huge cyst and many of the follicles are behind the endometrioma, we don't have any other option other than passing through the endometrioma, but at the same time cautiously not aspirating the endometrioma, and this option should also be considered. Sometimes accidental aspiration is quite rare with experience, because we are really cautious about it. But that also happens for beginners, and if it is done, we need to alert. We know all the protocols, alerting the embryologist, changing the needle, and because obviously the contamination would reduce the blastocyst formation and pregnancy rate. So intentionally, we should try to avoid it. And always we tend to go for complete aspiration, obviously at least more than 14 millimeter. Sometimes incompleteness is a conscious decision to avoid puncturing the endometriosis. Sometimes if we feel that ovarian reserve, we get adequate follicles, and 2 to 3 follicles are sitting behind the cyst, and why should we go beyond the cyst, transfixing the cyst, or sometimes accidentally rupturing the cyst? So we avoid those 2 follicles. That is possible in endometriosis. Incomplete follicular aspiration is 4 times higher compared to normal population. So cyst transfixation in almost 14% of patients, accidental contamination in 16%, and incomplete oocyte retrieval in almost 4% of patients. So obviously, there is a significant difference in the number of oocytes retrieved, compared to the follicles. So if we have unilateral endometrioma, obviously one ovary is normal, so we don't have incomplete aspiration in that ovary. So obviously significantly lower ratio between oocyte retrieved and developed follicles. So incompleteness is actually decision of the physician, and it is an intentional decision to avoid complications. The size of the cyst, does it matter, is the next question, but authors had concluded that there is no difference in technical difficulty at the time of oocyte retrieval according to the dimension of cyst. But at the same time, if we have larger cyst, there is a possibility of transfixation, contamination, and location of the, when do we say that the ovaries are normal in location? If it is lateral to the uterus, in the ovarian fossa, inside external iliac vessels, and behind also, if ovaries are not satisfying this criteria, it is said that it is dislocated. I'm going. obviously there is no difference in the, this is a trial published, concluded that there is no significant difference in the incidence of dislocation. But obviously we do encounter a few patients where the ovary is densely adherent to the pouch of Douglas. Sometimes we have difficulty in aspirating all the follicles. Sometimes every one of us would have gone for laparoscopic surgery, release of adhesions, and then we could reach the ovaries in a better way, and we get more number of follicles. But it is not significantly increased. So obviously everyone should avoid puncturing the endometrioma, because the possibility of abscess is relatively high in these patients, and also we are worried about the blastocyst formation. So ovarian abscess cyst rupture can be avoided by experience, and retrieval was not technically difficult, but we should always think about cyst rupture and pelvic infection. But obviously there is no difference in pregnancy rate between females with or without complete aspiration, and live birth rate is also not significantly reduced. We all know that with endometriosis, where fertilization rate is reduced with IVF, ICSI is always better. So oocyte retrieval in ovarian endometrioma is more problematic, and magnitude of these increased difficulties is modest, can be handled with experience. These appear to represent a clinically significant obstacle. So to conclude, oocyte retrieval in women with ovarian endometrioma is more challenging because of generally accepted assumption that puncture of these cysts should be avoided. The magnitude of these increased difficulties is, however, modest. Overall, the presence of these cysts does not appear to represent a clinically significant obstacle. So thank you, Ramani Madam and ICOG team, Sheelamani Ma'am and Pradik Sir, for giving this wonderful opportunity.
Thank you, Kalpana. That was wonderful. And as always, very to the point and very clear. Thank you. And Ramani Madam, Sheila Ma'am, Pratik Sir, can I leave? I have to just catch it.
Yes, of course. Please carry on.
Okay, you can.
Thank you so much for being.
I would have loved to carry
Thank you,
on.
dear Shashi, for being there. I always see that you are there always. Nice.
So I think the last speaker for the day is none other than Dr. Ramani Devi, our course convener, and it's appropriate that she is going to be lecturing us on the recent advances and research in this particular field. She has addressed some of these earlier in the first talk which she had on the first day when she spoke about new markers. I'm sure she will add more to our knowledge in her talk today. Thank you very much, and over to Dr. Ramani Devi.
Thank you, sir. Can you see that? See my screen?
Yes, ma'am, please go.
Okay. So now everybody has finished their own views about endometriosis, and the past 3 days it has been very fruitful, and the entire topic has been handled by the individual faculties so well. So I bring you greetings from Trichy, and I can skip this definition of endometriosis. Then why we need more research in endometriosis? Like somebody was discussing that maximum more than 50% of the research trials are registered only in endometriosis worldwide. So previously, what we had an idea about endometriosis was, it was a deep-rooted thinking in the past. It is just a gynecological lesion which has got positive data. Diagnosis means it's only by laparoscopy. Medical management was secondary, and removal of the lesion was the priority. Recurrence means incomplete primary surgery. ART wasn't safe and effective. No effect on the ovary. But the total concept has changed, and the current thinking is we know it is an inflammatory hormone-dependent tumor with the richness of data, no need for histological diagnosis to start the treatment, and medical management is the primary and it should be the main modality. And preservation of ovarian reserve is the priority when the patient is subjected for surgery. Recurrence means persistent offending factor, and it is not the incomplete surgery. And ART is nowadays safer and more effective, and endometriosis actually causes what is termed as nemesis of the eggs. That means the eggs are being killed because of endometriosis. So the prevalence, all of us know this, I can skip this. And now coming to the symptoms, I'm very fond of saying it as 70s, added to that fatigability, and you have associated signs like irritable bowel syndrome, headache, and chronic depression. So the therapies that are available today are surgical, medical, dietary, and there are digital apps to diagnose endometriosis, and of course, the physiotherapy, mindfulness, cognitive behavioral therapy, all those things are coming under the management. Now, the main focus of research is we need to have a non-invasive diagnosis. Second one is the medical management that should be focused long-term with least side effect, and surgical management should be more precise, it should be conservative, and it should be patient-centered. It is not a point-blank statement to say this patient has to undergo medical surgical management, and it should be individualized. And the role of AA in diagnosis, management, in assisted reproduction. These are all the main focus of research. So when you look into the first part, that is the non-invasive diagnosis, the research area is biomarkers. Example, that is, you have to focus on the proteins, microRNAs, cytokines, and the status is it is a promising candidate, not yet clinically validated, though soon we will be coming out with biomarkers as a mode of non-invasive diagnosis. The second one is regarding the symptom models, regarding the questionnaires using AI machine learning models. It is high early predictive value, still not a standard. It can be combined with the other things like the imaging. And in imaging and artificial intelligence, there is enhanced MRI and ultrasound evaluation that improves the detection, but still limited for some stages. Liquid biopsies. Somebody had asked, what is a liquid biopsy? It is nothing but the circulating biomarkers from the serum can be used as a potential future for a diagnostic tool. I have mentioned already, there can be even circulating endometrial cells which are found in patients with endometriosis. And combined together, the integrative approaches, all data have to be combined, and it offers the best hope for accurate non-invasive diagnosis. So the biomarker-based non-invasive diagnosis is from the blood. You can have a biomarker, or in the urine, menstrual fluid and saliva, and there could be proteomic biomarkers, microRNAs and circulating nucleic acid and endometrial cells, and immunological and genetic markers, immune cell profiles, cytokines, and non-inclusion, non-coding RNAs, and mitochondrial DNA, and multi-marker models, along with the clinical findings, imaging, and biomarkers. So the researchers are developing questionnaires and machine learning models that you can use for symptom patterns to estimate the likelihood of endometriosis. For example, the studies found that combination of specific pain patterns, that is dysuria and lightning-like pain, could predict. Then femtech tools like AI symptom trackers, wearable pain monitors, and biochemic biomarker tests aim to reduce the diagnostic delays. These methods may be particularly useful in primary care or early screening settings to decide who should undergo further evaluation. That means it is symptom-based, and these are the patients who are having more combinations of the specific pain patterns. They can be undergo early screening and further evaluation. So then the next liquid-based approach is testing circulating molecules in the blood that are being explored. Systematic reviews have focused on circulating microRNAs, proteins, endometrial cells, and metabolites to define a non-invasive endometriosis signature. These techniques are well established in cancer diagnostic and might translate into endometriosis, but validated high accuracy of liquid biopsy panels are not yet available clinically. So what I am talking is only future research. Then coming to the combined test strategies, emerging and integrative research approaches are advanced statistical models like the LASSO and AI are used to refine and combine clinical biomarker and imaging data to create a predictive model showing better diagnostic performance than an individual measure. novel sample sources or innovative studies are exploring whether the menstrual blood or the exosomes from the menstrual fluid as a newer diagnostic source, potentially enabling a simple home testing. Then coming to the advanced imaging and artificial intelligence role, ultrasound and MRI has undergone a lot of refinement, AI-assisted image interpretation, and multimodal imaging approach. Actually, this is an AI model of a MRI in endometriosis. Then advanced imaging and artificial intelligence. Multimodal imaging approaches, these methods can combine different imaging modalities. For example, ultrasound and MRI could be combined, and ultrasound trained AI can be applied to MRI. Then these are the things which are under study. And one research project developed an AI framework to recognize the nerve involvement in endometriosis imaging. So that is somewhat something very great. If you can identify the nerve involvement, then it can have a specific management, and surgery, during surgery, it may be of much use. Still, even the best imaging techniques cannot reliably rule out all forms of endometriosis, especially the superficial endometriosis lesion, and surgery remains only the confirmative method. Now, early innovations for early endometriosis, advanced imaging, including 99M technetium, macrocladite, and SPECT detects the superficial lesions for better trial patient selection. This integrates with trials to boost specificity and outcomes. So that means the PET scans can pick up even the earlier superficial lesion. Then what is MRI as a potential biomarker? This was a course study where he had studied control group versus endometriosis 24 patients. Pooled microRNA, miRNA, a microarray was done, and he has used more than 10 microRNAs to identify. And this was the result. These three are the microRNAs which are upregulated, and M3613 is the microRNA which is downregulated. So the same thing we have tried to do the same research work in our setup, and we have controlled group of 86 and 83 patients and endometriosis group of 86, and the pooled microRNA, miRNA microassay, we took up only not 10, but we selected the 5 to 6 miRNAs, and we were really surprised to see this, irrespective of the stage of the disease, these microRNAs were upregulated. Here you can see the control group, and in the mild, it is elevated. In the moderate, it is upregulated, even in the severe. So this was 125B, which was very significantly elevated. Similarly, microRNA 342 was elevated. And again, downregulation was between 3613 and LET7B. And LET7B showed a much downregulation irrespective of the stage of the disease. So that is wonderful. Even early lesions could be picked up. So this was the results of our study. And then future work is we are coming out with a kit, and we have almost developed the primer for this. Now let us see what are the list of clinical trials which are ongoing or recently registered in diagnostic non-invasive endometriosis trial. So the EndoSearch endometriosis biomarker study is one where identification and evaluation of biomarkers for endometriosis likely from the blood or other fluids like menstrual blood, serum, and the saliva. And type is exploratory research on potential diagnostic markers, and it is a registered clinical trial. Then came the biomarker in endometriosis with multiple biomarkers in blood, plasma, serum, and it is an observational biomarker study, and it is also a registered clinical trial. Third one was combining the ultrasound with the biomarkers, not a single one, neither ultrasound alone or biomarker alone will be have more, when the combination gives a more potential diagnostic approach to diagnose early endometriosis. Research combining the ultrasound imaging along with the biomarker analysis can improve the non-invasive diagnostic accuracy. Then came the EMPOWER study. It is an observational study collecting clinical diagnostic data, including imaging and biomarkers in women who are undergoing surgical and non-surgical diagnostic procedures, and this may aid as a validating diagnostic tools. Then comes the ultrasound monitoring and characterization of the endometriosis progression, potentially helping to redefine non-invasive imaging criteria. Once again, this is also a observational study which has been published very recently. Then came the ROSE2 trial, where menstrual blood analysis to predict endometriosis. It's a pilot study where there was analysis of menstrual blood samples to identify the predictive patterns and signals for endometriosis, which will soon become a promising non-invasive diagnostic approach. Then this is one important clinical and genetic research trial that has been done in India, that is EGRI trial, which was a multi-site Indian study where they have you investigating clinical features, genetics, and risk factors for endometriosis among Indian women. In a case-controlled research study with sample collection, that is most of blood was collected, that could help advanced biomarker and diagnostic understanding, women with symptoms suggestive of endometriosis and women who had surgically proven to have endometriosis were included. And this study is still ongoing and continue to recruit and aim at a reach of target of more than 4,000 women across India. Then comes the next generation endometriosis and diagnostic through comprehensive multi-dimensional analysis. The focus is a multicentric study, integrates genetic, epigenetic, imaging, and other data to improve the early diagnosis. And it also studies the uterine extracellular vesicles, namely the exosomes, which might serve as a non-invasive diagnostic marker. Then the clinical trials in endometriosis using drugs. First is GnRH oral antagonist. The suppressors, that is, we all know that selagogulic, relagolics, and linsagolics and tetraglolics. The trial focuses on reduction in endometriosis-associated pelvic pain, long-term safety with the add-back therapy, because that is being a medical management which is preferred in the treatment of endometriosis. We need to have a safe drug which can be used for a longer time, and it has to have a bone mineral density outcomes after the study. And current status is phase 2 to 3 completed for several agents. Post-marketing and real-world studies are ongoing. Then clinical trials landscapes in China and US, they lead the registration, emphasizing on the hormonal options like GnRH antagonist, that is linsagolic. In our country, we have the elagolics and the relugolics, but in US and China, they are trying with the linsagolics alongside of non-hormonal agents, that is gabergolin, targeting the pain receptors such as P2X3. About 30% of the trials involve interdisciplinary collaboration, with 2/3 ongoing as of mid-25. Then most advanced trials are linsagolic stops the phase 3 efforts, showing significant reduction in dysmenorrhea and pelvic pain in the Edelweiss 3 trial when combined with estradiol and norethindrone acetate. And other trials like SHR F280 and Estelle also advance in late stages for pain management, focusing on improved tolerability over the traditional agonist. Then prominent pipeline drugs are key candidates includes the prolactin receptor antibody, fertility preserving pain relief. Mostly all the drugs what we are using for endometriosis treatment are all contra-reproductive, but now they have come across with the prolactin receptor antibody, which can be used as a fertility preserving, at the same time can give a pain relief. Then there are other drugs which can target the inflammation, and selective progesterone receptor modulators, but ulipristal, we know the disadvantage, and progestins, of course, the dynegas, where we have had the adolescent Visada study, and the Indian study, that is Visa study, has been under publication. And then the aromatase inhibitors are the other drugs which can be used, and there are a lot of clinical trials going on with this. And non-hormonal things are anti-inflammatory, that has got a high research interest, or anti-inflammatory immunomodulators like tumor necrosis alpha inhibitors, pentoxifylline, and angiogenesis inhibitors, and neurogenic pain modulators like gabapentin and pregabalin and cannabinoid receptors. Then estrogen receptor targeted therapies, that is, which can selectively block the estrogen receptor beta, which is overexpressed in endometriosis, that can be SERMs can be used, and this is again one drug which can promote fertility. Then the novel experimental theories, early phase are microRNA based diagnosis therapies, stem cell pathway inhibitors, epigenetic modulators, antifibrotic agents, and mostly phase 1 and phase 2 trials are going on. And the key trials commonly measures the VAS score, non-menstrual pelvic pain, quality of life by endometriosis health profile, lesion size, BMD reduction, and recurrence rates. So in Indian practice, we have got mainly the dynegas study, GnRH antagonist, and progestin trial. Then there are a lot of surgical trials where the LAROS trial says that laparoscopy versus robotic surgery, robotic assisted laparoscopy surgery over the conventional study. And then again, robotic versus laparoscopic study in endometriosis. Again, it has proved that robotic surgery is better than conventional laparoscopy in DIE. And in ART, we have mostly the involvement of the artificial intelligence. We know this has been already mentioned. And we have the key clinical trial that is in 2025 OAT study, which shows that yields about 46% live birth rate in women with deep ovarian or deep endometriosis, doubling the rate from surgery alone. And again, we have the pregnant trial where oral GnRH antagonist pre-treatment improves the LBR, and EFFORT trial which evaluates the surgery versus direct IVF, focusing on the fertility impact. So the evidence highlights that surgery improves the outcome in 58%. Cadena SCR trial, large population studies which women diagnosed with endometriosis, that the higher pregnancy rate than some other infertility diagnosis, particularly when it is managed appropriately. And then the advanced computational and AI research. These are the models which can predict the outcome of what will be the stimulation protocol, what will be the yield of the mature oocytes, what will be the fertilization rate, live birth rate. All those things can be obtained from the advanced computational and AI research. And once again, I would like to say that stem cells has got a role still, that is both endometrial stem cells and the bone marrow stem cells can be used because of their pluripotent nature. This can be used for tissue repair, anti-inflammatory effect, targeting the mechanisms. Specific mechanism challenges in future directions are that in long-term efficacy, there is a risk of tumor risk and storage, and future focus, developing targeted therapies to correct the disease mechanism, improving the delivery using stem cells as a diagnostic markers. So you have the clinical takeaway is multimodal approach, individualized care, and early reference. So I thank you for the opportunity given. So endometriosis life, roots in utero, starts at 20, progresses at 30, problematic at 40, supposed to end at 50, malignancy at 60, and needs lifelong follow-up. Thank you. This is the team with whom I work.
Thank you very much, Dr. Ramani Devi.
Thank you. A
Fantastic
real clap
presentation.
for you.
Thank you, madam. Thank you.
So I think we're at the end of our 3-day course. I would request Shreya and the backend team to share the link for the post-test, please.
Yeah, let them
Dr.
solve.
Ramani,
So,
thank
Dr.
you for
Ramani.
making me a part of this.
Yeah, thank you.
Thank you. Thank you. Thank you so much.
Because the post-test will take 15 minutes, and during those 15 minutes, I think we can do the gratitude and Thanksgiving.
Yeah. So I would like to share something. I have
Yes,
written there that I have a good news. So
Yes, ma'am.
We were waiting to
whatever,
hear the good news.
I think Dr. Ramani, a lot of appreciation for this endometriosis course. Just now I was in one scientific meet, people from Bangalore, everybody is appreciating, and really thanks to you for our first certification course coming out with such a good attendance. As Dr. Pratik already mentioned that I think record break, right? Pratik?
Absolutely.
For all the
I've been
programs,
following
on
the
the top
courses
of that
since
for,
inception, since so many years.
yeah.
We've never had such a high attendance.
Yes. So for all our masterclass, for Guru Mantra, and for certification course, excellent attendance and very, very good, very much appreciated. So the good news is, Dr. Ramani, we are going to come out with ISBN book. Okay, Pratik?
Yes, ma'am.
Yeah, so whatever topics we have covered, we will
Yes.
have to share. Okay, Pratik?
Sure.
And Sun Pharma has agreed to do that.
Okay.
And copies as many as, so that it will be distributed to each and every, that is ICOG, it will become a ICOG editorial, and we will be distributing it to all. So that is the good news, Dr. Ramani. So
Congrats, madam. Congrats.
yeah, so we are going to do that. Okay. So
Awesome.
whatever we have covered, nobody will
Congratulations,
miss. Those who are listening, you will get it on the ICOG website after a week, but it will come to your doorstep. And particularly those who have attended and those who have registered, we will have their number and email ID, and we'll see to it that you get the copy. Yes, Dr. Pratik? I think 1,900 people registered with us. So
Yes, ma'am.
So
The
we will
backend
see
team
to
will do
it
the
that,
needful.
yeah, we will do
And
that.
coordinate with the office.
Needful. And after this, I have some announcement. As I told you, we will share the flyer regarding Bangalore conference and convocation. for FICOG again at Bangalore. The applications are available again for FICOG on the website. And we will also share the flyer. Dr. Parimala, thank you for being there for all the 3 days. Very nice to see my friend, Dr. Parimala Devi from Bangalore. Thank you, Uma, Deepa, Shashibala, all being there today. Kalpana, Archana, all very good talks. And Dr. Ramani, I think you have done a PhD in endometriosis, right?
Yes.
So you're real, I must say that just can't call you as a master, I think doctorate now, doctorate.
Double doctorate.
Double doctorate. So very nice. Yeah, Shreya, if you can unmute one of my friend, Dr. Parimala Devi, who is in the crowd. I mean, in the delegates
Yes, ma'am.
and her video also, if you can do that for Dr. Parimala Devi.
Yes, ma'am.
I have sent her an unmute request.
சொல்லு பாரதி ஒரு வழியா
Yeah,
இழுத்துட்டியா
yeah, can. I'm really excited so much to go through these 3 days mega webinar actually. And it was every talk was so good, even though in between the work we missed a bit. But as you are giving the recording and everything, we are very, very fine. Actually, it totally refreshed with endometriosis because we get into so many work and we start like we definitely need a refreshing talk, especially endometriosis because the incidence is so high. And my dear friend Dr. Sheila, and who was my president in BSOG, I'm so proud that you have come out with such an excellent ICOG seminar in the very beginning of your tenure. And Pratik is, Dr. Pratik is no way less very supportive and very crisp. He looks like a military officer to my eyes, to the point, telling, and no less Ramani madam and Malya, everybody, congratulations. Really appreciate and look forward for more programs to learn more. Thank you so
Thank you
much.
very much. Thank you for
Thank
the
you.
appreciation. Really appreciate it. Thank you for
Thank
being there for 3 days.
Thank you, Parimala.
Thank you, Sheila. God bless you.
We got your Parimala.
Yeah. Pari, ye Pari kaha se aayi, you can tell. Okay. Thank you.
Thank you. So if you are listening while solving, again, and next month we will have a master class on placentology. So it will be very interesting, and certificate course on infections in pregnancy.
Besides the other ICOG web series like Research Methodology, PG Clinic,
And
Guru
if-
Mantra,
yeah.
all of those will continue as usual.
If the postgraduates, I think for postgraduates, we will have 3 programs. Next month, we will
Yes.
start Gurukul also.
And we have Odyssey also.
Yes, we have 4. Okay, we have 4 programs, yeah. And we are also starting our online 7H CMAs.
Yes.
Yeah. Starting our critical care workshop, Pratik, health system strengthening,
Yes.
CICO, okay, skill
Awesome.
development. First, I am doing on 4th of February at Hubli
Very nice. Congratulations.
Medical College. Okay, so there are some 3-4 medical colleges, so we will be doing that.
Congratulations. So we cannot send links for the first 2 days because the answers to those questions have already been discussed. So apologies, you will only see the links for today. So today everybody is very quick. They've managed to finish in less than 10
Yeah,
minutes.
yeah. They have started submitting.
But we'll just wait until the
Yeah,
requisite
the time
15
is
minutes
over,
are
correct.
over, because many people will log in late
Mm.
and then they complain they didn't get enough time.
So all of you keep logging in for our future programs also and spread the message. Okay. घर बैठे सीखो.
As I'm used to saying, ICOG is our organization. It is an
Yes.
organization of academicians, those who want to do better for their patients, and those who want to keep learning. So we learn from each other and we contribute to each other.
मस्त आहे.
Certificates will be sent by email, no? For everybody,
Yeah,
all the participants.
e-certificates, and we'll have separate faculty certificates as well.
Certificates, yeah. Mm.
Somebody is not able to submit.
Just you have to clip the submit thing, that's all.
Thank you, Dr. Geeta, being there.
Geeta madam started calling me by 3. She has sent messages which I didn't see. She called me at 3:30.
So it was really enjoying, very good.
Thank you, madam.
My postgraduates also attended. They were so happy.
Awesome.
Sir, which city and which college?
I'm in
From
Lucknow.
Lucknow. Dr.
Okay,
Neeta
great,
Khanna is
great.
one of our center heads. She
Yeah.
has 2 students for the ICOG reproductive medicine course, and recently she's also
A
taken up the
laparoscopy.
critical laparoscopy as well. Yes, I remember that. Some of our best students come from her center. I remember during the exam.
So Kirti is there.
Yes,
Shabnam is there.
I
This
know.
year we are preparing, made them a benchmark, do very good.
Dr. Anita has done. Anita has put. Anita could have shown her face now. She's a GC, Governing Council.
She
Anita,
must be driving, madam. She is busy usually, multitasking. Once or twice I have seen her driving while she's attending. Today I'm not leaving the office until the course is complete, because once I get into traffic, I don't know what sort of network it is.
you are in office?
I'm sitting in the office. I'm the last person in the office. Everybody's left at 6 o'clock.
Busy day for me.
Yes, ma'am,
Every day is
multitasking.
going to be busy for you, Sheila. As a
Morning, I had
chairperson.
one vault prolapse. After that, one emergency section. Then I did my OPD, went for that Sun Pharma program. Again went with for DHO program, gave a talk about the girl child. Came back for again the panel and then joined here. And again, in between, did my OPD. Few are waiting still.
There's some query regarding a certificate course which was held in February 2025. How do I get the certificate for that? Oh my God. You'll have to send us an email. I'll have to look at the records. I'll ask Nilima to check the attendance for February 2025, if it is still available, that is. And we'll get back to you. Please send us an email.
Oh, February last year.
Yes, that's 1 year ago. If we have the records, of course, we will send it.
So 2 more
Earlier,
days.
how much we used to have attendance, Pratik?
We used to have about 150, 200 max.
No, for
I've not seen
certificate we
more
had
than
more,
200.
no?
If you take the cumulative attendance of all 3 days and the people who qualify for the certificate, it's not more than 152.
Acha.
And we've never
Are we
exceeded
to
300
give
simultaneously.
Sheila, Dr. Sheila and Dr. Pradeep, do you feel that we should give some certificate for people who have attended at least all 3 days?
I think so. I agree. I
So I was
agree.
just speaking to Nilima in the office before we
I feel
started
so. Even
today's
I
session.
felt, Dr. Ramani, because
Yeah.
spending 3 days is also great, I mean,
Yes.
yeah.
Especially for those people who had technical glitches, they were unable to submit, or the
Yeah,
form
yeah.
didn't go through, they had some
And they have attended all 3
issues.
days, Pratik.
Yeah. So
Give
I
a
think at
certificate for
least for this
everybody who has
first
attended all
session,
3
this
days.
first certificate course, I think we can do that.
Hmm.
From the next time, maybe we'll be a little more strict so that they actually attend.
But I think we should give them for if they have attended 3 days, and those who have that we will discuss regarding that. Okay?
Sure,
Dr.
ma'am.
Ramani?
Yes, ma'am. We have 1 minute to go to final
We
submissions,
will have
and
a
then
forethought about that.
final submissions, and then Dr. Ramani Devi will give us the answers to today's questions.
Yes.
But I am appreciating their enthusiasm.
Hmm.
No, especially in the interiors where they don't get good quality speakers and they don't have such focus sessions, ICOG certificate courses are always appreciated. Because we come from major metros and we have a choice of 4 or 5 programs every weekend, we are spoiled for choice.
Not a
So
one
we are
weekend
used
also
to
they
it.
don't leave us.
Exactly, exactly. So we are used to it in the major metros, but when you go to opportunities for learning are few and far between.
Really, very true. Very true.
Dr. Sheila, I am going to plan a certificate course, like not a certificate, exactly a webinar series for 6 months, 2 days a month. Webinar series on exclusively on endometriosis on behalf of Endometriosis Society India.
We'll give you ICOG points.
Yeah, I am going to apply, madam. Last time also I got it. Last time also I got it. Last
So the
time it was
time is
only for
up.
3 months, but now I have extended to
The
6
time
months.
is up.
Yeah, yeah.
Time is up, and we can now have the discussion of the answers.
yeah.
Dr. Ramani ma'am, you can please go ahead
Yeah.
and share the screen.
So the form correlated with endometriosis die phenotype significantly in 60 to 65%. First question. Then what causes fertility in women with endometriosis? All of the above. Third question is, what are the effects of chronic pelvic inflammation due to endometriosis on fertility except good implantation? Then endometriosis affects sexual domain. In all of the above is the answer. Then, which is better option for management of sexual dysfunction, hormonal treatment or surgical? It is surgical. Endometriosis causes which type of dysmenorrhea? Both superficial and deep dysmenorrhea. Current recommendations regarding endometrioma excision prior to ART are not in favor of routine excision. Okay, then the fecundity rate in normal couple in approximate is 20%. In endometriosis, it is 1 to 3%. And which type of an ovarian cancer is commonly associated with endometriosis? Is a clear cell carcinoma. Endometriosis associated ovarian cancers most commonly arise from which type of ovarian cyst? That is endometriomas.
Shreya, you will need to scroll down, please. Yeah.
Yeah, that which I am scrolling down from my mobile. Okay. So then the next thing is, which genetic mutation frequently found in endometriosis associated ovarian carcinoma is Aridia mutation, Aridia 1A mutation, and a 40-year-old woman with long-standing endometriosis presents with the rapidly enlarging ovarian cyst and new solid elements on ultrasound. What is the most appropriate next step? You have to go for a surgical evaluation. C. Answer is C. Then, which of the following histological types of ovarian carcinoma is least associated with endometriosis? High-grade serous tumors are least associated. Which of the following best explains implantation failure in endometriosis is progesterone resistant? What is the primary advantage of FET over fresh embryo transfers in endometriosis is avoidance of supraphysiological level of estrogen. And then which FET protocol is preferred in moderate to severe GnRH agonist downregulation followed by HRT. Adenomyosis primarily affects fertility by that is impaired uterine contractility and receptivity. Which molecule is reduced in endometriosis affecting implantation? HOXA10. And then endometriosis trial conducted in India is Endometriosis Clinical and Genetic Research in India. That is the ECRI trial that was conducted from Mumbai. So these are the correct answers.
So on behalf of ICOG, I would like to present my gratitude to our course convener, Dr. Ramni Devi, the coordinators for the 3 days, Dr. Asha Rao, Dr. Subhash Malya. We also had Dr. Kanti Bansal and of course Dr. Shashi Kabra Maheshwari who came in. So thank you very much, all of you, for all your mammoth efforts towards this 3-day course. I can say that the talks have been of the highest order, the most evidence-based, updated presentations. Thank you, Dr. Sheila Mane ma'am, for giving us this opportunity to conduct this 3-day course. As I mentioned earlier, we have over 1,900 registrations and simultaneously we had more than 650 attendees at one point of time. I will now hand over the stage to Dr. Ramani and Dr. Sheila Mane to present their hand.
I think I am really honored to conduct this certificate course as a convener under the leadership of Dr. Sheila Mane and Dr. Pratik. So she gave me the task when I met her in the last annual conference at Bangalore. Then within a short period, we could program all the topics, and then I had submitted to her and she said, okay, she did not even say any word. Because who she thought would be appropriate for that particular session, and I have added them. And I'm really thankful to all the chairperson and all the speakers who have immediately agreed when a message was sent to them. This is not possible without the coordinators, Dr. Asha, Dr. Mala, Dr. Subhash, and one more person is not
Kanti.
Anita, not Kanti madam, and
Shashibala.
Shashibala. All of them had did their work excellently, and I should also congratulate Nilima, who was behind me every day in getting all these MCQs. So I'll be sending her MCQs only at the morning 11 o'clock because only after my assistant comes. So anyway, I really enjoyed this. In between this 4 hours of program, though I had lot of emergencies, now also we had a PPH in the labor ward, which was very effectively handled by my assistant and my daughter Archana. So I think I am so much grateful to my colleagues, my assistants, and my family members for permitting me this 4 hours of time every day, just sitting in front of the computer. So it was nice enjoying all 3 days, and I hope I should continue my work with ICOG. Thank you so much.
Thank you very much, ma'am.
Thank you, Dr. Ramani. I don't have words to thank. Okay. I mean, hello, Dr. Geeta. Nice to see you here. Dr. Geeta Shanbag, madam, our senior most gynecologist. I can see her video and really appreciate. She's very senior. You know, she has 100% attendance in our BSOG sessions. Okay.
Awesome.
Now also. Yeah.
Shreya, there are 2 slides that madam wants to share.
And
Can you just share those last 2
we can
slides?
have that and I keep continue talking. You
yes,
can. Okay. So yeah, all of us sitting in front of our system for 3 to 4 hours. So, but it was worth, I think. And we are spreading knowledge. So Vidya Devate is, I think, will be happy with us and will shower more blessings on us, because in ICOG, we are only with academics. And Dr. Pratik, thank you. You're always there, I think.
Thank you, ma'am.
And in the background, and I must tell the staff, okay, Shreya, the back end who is handling this, and Nilima.
Nilima and Poonam.
Yeah, I mean, excellent work happening. And in between also, we had so much of work and so many things to be handled. And nice to see Subhash full attendance today.
Subhash is out of OT today. He is confessed that there is no.
Otherwise, always, you know,
for us.
we have to see him, you know. So this is the slide. Please don't forget to come to Bangalore. There is a national ICOG conference, 22nd, 23rd of August. Very soon you will get all the details. And those who are eligible to apply for FICOG, you can start applying. Last date is 15/7. Okay. And convocation will be held in Bangalore and next will be in AICOG at Surat. We are looking for more and more people joining ICOG so that more academics And we will do evidence-based practice, which will definitely help the community and the women of our country. So thank you all once again.
Thank you, everybody. Goodbye. God
Night.
bless.
Good
We will
night.
see you in the next course. Same
I
dates,
wish if we would have
24,
been in a hall,
25,
we could have
26.
given a standing ovation to Ramani. If we
Yes.
would have been in the hall.
Thank you. Really honored.
Bye, everybody. Good night.
Bye.
Thank you, ma'am. Thank you very much. Thank you, sir.
Bye, Shubha.
Thank
Yeah,
you very
bye.
much. Thank you.
Recording stopped.
Thank you, sir.